I welcome all the physicians and the eminent faculty to Indian Academy of Diabetes Conference 2022 GLP-1 edition. And as you all know, we are here to discuss the newer advances in diabetes care with special emphasis on the clinical outcomes of the emerging therapies like GLP-1 receptor analogs with their additional pleiotropic benefits, which has led to newer possibilities in the management of diabetes. To host the session, we have none other than Dr. Shashank Joshi, who is the eminent endocrinologist and from India and chair of International Diabetes Federation Southeast Asia, and also an endocrinologist at Joshi Clinic, Lilavati Hospital, Bhatia Hospital. And sir has also been member of COVID-19 Maharashtra State Task Force since 2020, and also the immediate past dean of Indian College of Physicians and past president of API and Indian Academy of Diabetes and Hypertension Society of India, and also past president of ESI, RSSDI, and IRO. And sir also is the emeritus editor of JAPI, and sir has been a part of many national and the international congresses and awarded with International Clinician of the Year in 2012 by American Association of Clinical Endocrinologists, and also sir has Padma Shri awardee from Government of India. With this brief introduction about Dr. Shashank Joshi, sir, I need to hand over the stage to sir.
Thank you, Vijaya. On behalf of Indian Academy of Diabetes, I welcome everybody and wish everybody very happy Hindu New Year. Let's all rise for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Jai Hind. I now request our Chief Speaker, Dr. V. Mohan, to join here for the lamp lighting with Dr. Ashok Kumar Das, all our eminent faculty, Dr. Sunil M. Jain, Dr. Rajesh Rajput, Dr. Sriram Godbole, Dr. Hemant Fatale. Please join me here to light the lamp. I would also request Dr. Anil Shande and Sri Rekha from Novo to join me in the lamp lighting with Vijaya. Dr. Mohan can do the honors.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीप
So we have a busy agenda today, and we are all here to listen, learn, and adapt something new which is now happening. And we all know that we are all eagerly looking forward to the oral GLP-1 which has arrived. So let me do some context setting. Can I have my slides, please? But it's not working. So we have all been in the incretin journey for some time now. And there has been an incredible expedition of incretins in diabetes care. So to set the context, we all know that type 2 diabetes is a relentlessly progressive disease. And we all know that normal glucose metabolism is determined by a feedback loop involving the beta cells and insulin sensitive tissues. And clearly this dual defect has gone into a dirty dozen and so on and so forth. But we know beta cell failure determines the rate of progression of the disease. So that's something which is very clearly established. We also know that there are a lot of genomic and environmental factors which cause type 2 diabetes. And we know that the insulin resistance in the peripheral tissues, the beta cell insulin secretion from the pancreatic beta cell lead to elevations of hyperglycemia. And we know that the tenets which determine this are genes, environmental factors, but the overarching feature is probably obesity. So clearly when we look at the circle of wheel in understanding the pathophysiology of type 2 diabetes, it's just not beta cell insulin secretion or excess glucagon output or a blunted incretin effect or excess hepatic glucose diarrhea, but it's also linked to the central nervous system appetite regulation, the muscle GLUT4 glucose uptake, the lipolysis which is increased, and of course we all know the renal effects of renal resorption. We also know that there is a new term which I learned from Professor Kamlesh Kunti called multimorbidities now. Diabetes is a complex multifactorial multimorbid disease, and that contributes to accelerated death. We know diabetic people living with diabetes die earlier. They have multimorbidities, whether it's cerebrovascular, whether it's cognitive or emotional challenges, whether it is retinal or blood pressure or cardiovascular issues, whether it's cancer, gastroparesis or obesity, whether it's nephropathy or chronic kidney disease or vascular disease or neuropathy or foot and skin impact. Fundamentally, there's a 13% to 15% increased mortality and around 15% excess cardiovascular death. And we know that the relative importance of cardiovascular risk factors in type 2 diabetes is all linked to sedentarism, as Dr. Mohan calls it, and of course, a lot of other factors, including smoking and A1C. We also know the clear links between acute myocardial infarction and strokes. But when it comes to heart failure, which is the new elephant in the room, it's BMI. So we all know the relative importance. But as I told you, it's diabesity which is the overarching feature. And that clearly increases the risk of type 2 diabetes. And 90% of people with type 2 diabetes are either adipose or overweight. And that risk keeps on going up. And it's earlier in our race, in the Asian phenotype, which Dr. Mohan has elegantly described. And it's the ethnic group which confers us a unique disadvantage. We have a high family history with hypertension. And we also know that diabetes has a significant impact on the budgetary allocation. It has an impact to bankrupt economies. So that's something which we know better. And we also know that evolving treatments and the way we treat people with type 2 diabetes has changed. It's not just a glucocentric approach. We have to factor in weight. We have to factor in reduction of cardiovascular disease and heart failure. We have to look at the renal risk reduction. So it's a multifactorial approach. But weight, heart failure, heart disease, kidney disease have become the norms now. So that continuum of type 2 diabetes, whether it's heart failure, which is non-atherosclerotic cardiovascular disease, and as we talk, the ACC is meeting in the US, or AVCSD, that is atherosclerotic vascular disease, the vascular clock starts ticking almost the macrovascular clock a decade or two before onset of diabetes. And the microvascular starts ticking a little later. And then of course we have cardiomyopathy which sets in. Obviously, the SGLT2 is a hemodynamic effects. But when it comes to stabilization of plaques, anti-atherogenic effects, GLP-1s also have a role. So both these compounds have been game changers. Whether we like it or not, there has been a clear game-changing potential with both these compounds, SGLT2 inhibitors, and now with SGLT2 in the generic space, that has made an impact, a palpable impact on the current environment. But today's focus is going to be on the oral innovation of GLP-1 because that's really a game changer. When it comes to early disease, pre-diabetes, we don't have much of data. So when we look at this expedition, current management in diabetes care is patient-centered. It's target-driven. It's very holistic. And it's using these newer modalities which have a very novel mechanism of action, and it is going to have a larger access to both GLP-1 and SGLT2s. And therefore, we need to embrace this as a paradigm shift. We need to definitely make a sea change, because at the end of the day, we want to improve the people living with diabetes should have better outcomes. And that is the final thing which we need to do. So we are going to put the spotlight back on the incretins in diabetes care and on GLP-1. And that's why Novo Nordisk decided that India is one of the unique countries which has this molecule with us, and therefore we are going to learn a lot about that today and look at the value story of optimal glycemic control. So obviously in this whole expedition today, in the GLP-1 edition, we have some extraordinary speakers, a galaxy of speakers. So this meeting is not only for the audience here, but to a larger audience which is being telecast. And we are going to have our inaugural speaker and our chief speaker, Professor V. Mohan. He's a living legend as far as India is concerned. He's a guru, diabetes guru of India on the world. He has the highest H-index impact factor in the medical specialty across all branches. He's going to tell us the story of the concept of incretins, the discovery of incretins, the evolution of incretins. Then we have one of the foremost endocrinologists from Pune, Dr. Srirang Godbole. He's going to talk to us on the birth and journey of CVOTs, how the last 2 decades and the cardiovascular outcome trials, how they have given a perspective. And he's going to give us a flair of that. And then focus a little bit on GLP-1. And then we have one of the foremost endocrinologists from Indore, Central India, Dr. Sunil M. Jain. He's going to tell to us how to spread the wings beyond diabetes using GLP-1 as a target. So it really gives me a lot of pleasure to introduce Professor V. Mohan. As I told you that he's a living legend, we all virtually respect him, worship him. He's a chair and chief of diabetology at Dr. Mohan's Specialty Center in Chennai. He's virtually omnipresent all over India. It is a center of IDF for excellence in diabetes care. He has a chain of more than 50 centers in 8 states. He has 5 lakh plus registered diabetic people living with diabetes. He's also, as I told you, one of the most avidly published scientists on planet Earth. And apart from CNR Rao, who's Bharat Ratna, according to me, our diabetes Ratna and Bharat Ratna is Dr. V. Mohan. And he has the largest standalone diabetes research center at Madras Diabetic Research Foundation. He has been the president of the Madras Science Foundation. And at his center, he has been looking at not only public health and epidemiology of diabetes and its complications, but also has a special interest in type 1 diabetes, monogenic diabetes, FCPD, and his current interests last year, the American Diabetic Association did a conference on precision medicine. And Dr. Mohan was the lead scientist in that. He has a very deep understanding from his medical student days. As I told you, he has published more than 1,500 plus papers in peer-reviewed journals. and his H index is 138. So he's probably the top scientist in this part of the world. And he's not just a scientist and researcher, he's also a clinician par excellence, a human being par excellence. He has done a lot of capacity building program for physicians and diabetologists, whether it is diabetes educators, nurse educators. He's a BC Rao awardee. He's the Dr. B.R. Centenary Award, the highest biomedical research award by ICMR. The American Diabetic Association, couple of years back, honored him with the Harold Rifkin Award. He's a Padma Shri awardee. He's a fellow of the Royal Society of Edinburgh as a FRS. He's a MAC, member of the American College of Physicians, a master. He has done cutting edge research and was a Padma Shri awardee in 2012. But what is unique is, beyond his clinical habits, research and education, he has made excellence his way of life. And if you have not read, it's a must read, Making Excellence an Habit, autobiography which he has put out on the secret of building a world-class healthcare system in India. If you go to Dr. Mohan Center, you don't need to really go to Jocelyn Clinic. I think his center is far beyond Jocelyn Clinic, and it's a bestseller. And he has a huge spiritual intent also. He works for the Satya Sai Foundation, voluntarily, selflessly, and he's a selfless worker, as one would call it. So Professor V. Mohan is going to give us the original glimpse of GLP-1 story. Professor V. Mohan.
Thank you, Shashank, for that very generous introduction. Not sure they deserve all those accolades that you had mentioned. Also very grateful to Novo for inviting me. Until quite recently, I was not brave enough to attend conferences, but I think starting with this conference, hope to start increasing my travel, not only in India. I still haven't been abroad, incidentally, in the last 2.5 years. But starting with ATTD in Barcelona, which I think Shashank and many of you will be attending, probably try to resume our life as it was pre-COVID. Thank you, Shashank, for that excellent introduction. You have really brought us all on the same page. And the overarching message which comes out from your talk is that unlike 10 or 15 years ago, when all we are bothered about was the A1C, A1C came down, that's fine. Today we know that diabetes control is far beyond just A1C control. It's not just glucose-centric, and we must have a larger picture in mind. So that's what is going to be here. And what's very interesting and fascinating, some of you may know, some of you may not know, is that the GLP-1 story started long before insulin. Very surprising it is that insulin went so far ahead and GLP has taken so much of time. But as in philosophy, we say for everything a time has to come. And for GLP also the time had to come. So it took time. So that's what I'm going to talk about. So of course, these 4 heroes of diabetes we've been talking about repeatedly ad nauseum, because last year was the 100th year of insulin. What happened? It's gone off. Okay, it's come back. So these 4 heroes, Banting, Best, Collip, and MacLeod, I won't go into the controversies, how they never even spoke to each other. They don't have a single photograph together. So that's a different part of it. But then all 4 of them contributed. And today, if children with type 1 diabetes are alive, it's because of these 4 gentlemen. I always tell my patients with type 1 diabetes, make a photograph of, you keep all God's pictures, make one photograph of these 4 people and keep it in your house next to you. You'll always remember that these are the 4 gods of diabetes who saved your life. So our God sent them specially to earth for this. Banting, for example, he did nothing beyond his, one of the most eccentric fellows. You read Banting's life, he's one of the most eccentric, arrogant people that you can meet. He was born for this. After that, he did nothing. He tried to do cancer research, he tried to do this. Only thing he did was a few paintings. He did a few paintings, became one of Canada's good painters, and then he died in an air crash also. But that is how history was made. But then, if you look at the GLP-1 receptor analogs, here we are in 1921, right there. 60, 70 years before that, 1840, 1850s. Already Claude Bernard has been talking about it, and this incretin concept has already been talked about, even before insulin was talked about. And then, of course, over the years, it led up. And some of that I'll just very briefly tell you. In 1878, Claude Bernard explained that significantly larger amounts of glucose can be given orally than intravenously without glycosuria. And I remember this paper which, our Dr. The one you wrote the commentary for, B.C. Roy. Dr. B.C. Roy did similar experiments. You would be surprised to know that Dr. B.C. Roy has done a lot of work on diabetes, and it was Shashank who alerted me to that, and he sent me one of B.C. Roy's original articles on which he wrote a commentary. Such work has been done even in India. And then, of course, we had Bayliss and Starling and many others who worked on this. Then came Labar, and then McIntyre, and Perley, and Kipnis, and many others. But then, history, is interrupted. In fact, if World War had not come, before Banting and Best, they had already discovered insulin. People are going on. The lab was closed. They had all run away. And so that's why the delay took place until 1921. Otherwise, before itself, the insulin would have been discovered. So this has been going on for many, many years. But it was Bell who named two novel GLP hormones in the gut, and he named it as GLP-1 and GLP-2. I remember when I was in Germany in 1985, 86, Cruikshank was working on quite a lot on GLP. Nobody kind of listened to them also. Why are these people working on these rare things which are not even important? Because there's no clinical application of this. Something they find, some paper, they publish something, and then they say, okay, interesting, that's all. Boring but interesting. And then they used to move on. And then started the work from Jens Juul Holst and Frank Habener, who showed the further physiology of the GLP, how it works and how it releases insulin. And then it started getting interesting. And of course, Juul Holst was recently talking to us in one of the meetings from amazing guy. I would be surprised if he doesn't get a Nobel Prize. Now, this is in summary what actually happens. If you give to a healthy controls, if you give an oral glucose load, there is a tremendous increase in the insulin secretion as compared to, is there a pointer here? This green one is a pointer? I don't know, yeah, but it's too bright, it doesn't work. In any case, you can see the bottom line, the green one is after the IV insulin in normal people. And if you give the same glucose orally, you can see the stimulation. So obviously, if it is IV and it can produce insulin, how much more is being produced when you give it orally? That means something is happening in the gut. Something when you give the oral glucose is going and stimulating the insulin. That, of course, is now we know is incretin effect, incretin hormones, GLP, and so on. Now, in type 2 diabetes, the problem is that it's blunted. Not only the pancreatic insulin secretion is blunted, but the incretin effect is also blunted. And that's why when Roger Unger, when he described glucagon, he kept saying glucagon is as important a hormone as insulin. Again, 1968, when Unger said that, nobody believed him. And it took years before we knew that these drugs have some effect on glucagon. Because there's no, once you don't have a clinical application, these things are just kind of shelved away. Oh, some observation somewhere, they shelve. Only when it has a clinical implication, we start looking into that. Now, what GLP-1 does is, if you give GLP, you can see that the glucose levels coming down, as you can, I think it should come in a tap, yeah. So you can see the glucose levels coming down, but you can also see the insulin levels going up. And the glucagon, which is higher in people with type 1 diabetes, going down. So you have two defects in diabetes, as you know. One is insulin levels are low, and the second, glucagon levels are higher. Both are kind of corrected by GLP-1 analogs, or this group of drugs, which no other drug does, by the way. Sulfonylurea doesn't do it, metformin doesn't do it, SGLT2 doesn't do it, nothing else does that. So that is a unique part. And if Unger was right, these are the only drugs which actually address the glucagon problem in diabetes. Now, what is the purpose of incretins in the body? As far as the pancreas is concerned, I already alluded to the fact that as far as the beta cells are concerned, they increase insulin secretion. As far as alpha cells are concerned, they decrease the glucagon secretion. So that we know very well. But it also has hepatic glucose production is reduced, gastric emptying is reduced, satiety is improved. It works on the brain, and that's why people stop eating after some time. This has been done in animals. When early studies on GLP, you give this to rats and you give them food or mice, they don't eat. After some time, they stop. Snacking comes down. Remarkable effect. Again, I don't know of any other anti-diabetic molecule which actually does that. And therefore, the food intake goes down, leading to loss of weight. And then more recently came the beneficial effects on the cardiovascular system. And for that, I think the next speakers will be talking about the CVOT trials. It's only after FDA mandated the CVOT trials that beneficial effects were described. To an anti-diabetic drug, the poor drug which is just supposed to reduce your A1C, now protecting the heart and preventing heart failure, and not heart failure is not for this with SGLT2, but preventing heart attacks and so on, something totally unexpected, a big bonus for a drug. So the effects of GLP-1 are, the plethora of effects that you have, pleiotropic we call it. So it affects, it has effects on the pancreas, beneficial effects of course, brain, the liver, GI tract, heart, bone, muscle, kidney, virtually everywhere. It's almost like a panacea, if you can really study. I don't even know what are all the effects. Every year we're discovering, it's like metformin. Every 3-4 years we discover a new mechanism of metformin. 50 years after the drug came, we're still discovering what metformin does. Anti-aging, anti-cancer, anti-this, anti-that. Every 2 years, 3 years. So I'm sure the next 20 years, lots more will be discovered about these molecules. But suffice to say, that all beneficial effects, weight reduction, decrease in fatty liver, decrease in inflammation in the liver, even in the brown tissue, brown adipose tissue, increased thermogenesis, white adipose tissue, increased perfusion, decreasing inflammation. All these are very much beneficial. Now coming to, then why don't you just use human GLP-1 and just use it? Go ahead and use it. Unfortunately, it has a very short half-life, as you can see here, just 5 minutes. So if you have to give an injection or continuous infusion throughout life, you'll have to have, if you're using these molecules, which obviously is not going to work. And that is why you have to develop an agonist which resembles the molecule and yet carries out the functions of GLP. Now there are two ways you can do that. GLP, we know, gets degraded. So you can use a tablet like the group of drugs like the DPP-4 inhibitors to prevent that degradation, and therefore the endogenous GLP-1 levels are increased, or you can use a GLP-1 receptor analog which can take it directly to supraphysiological doses and lead to increased insulin secretion, decreased glucagon, and plus many other benefits, of which decrease in appetite and weight reduction will be on top of the list. And of course, it's because of this decreased gastric emptying that you get this little side effects of nausea and so on, because directly working on the stomach. Now, if you talk about the GLP-1 class, it's highly heterogeneous, and I'll show you 3 different classifications. It's like neuropathy. Trying to classify neuropathy, you can classify it in 100 different ways. So like that, I think the GLP-1 receptor analog, you can first classify it as an Exendin-4 based GLP-1 receptor analog, which came from the Gila monster and so on. Then you have the acylated human GLP-1 receptor analogs, and then the macromolecular human GLP-1 receptor analogs, and all the different classes, exenatide, lixenatide, liraglutide, semaglutide, dula, albiglutide, all of them using different mechanisms, basically to keep them working longer so that they don't get destroyed, and therefore the effect lasts longer. Now you can also classify them based on GLP-1 based therapies, under which will come albiglutide, dula, sema, and lira, and then the exendin based therapies, where you have the exenatide, extended release, or the BID, or the lixenatide comes there. Now, it can also divide them based on short acting with a short half-life, or a long acting or a long half-life. And the long half-life, of course, helps you to give the drug once a week, or even once in 2 weeks you can think of, and so on. Whereas the short-acting ones are only few hours. So sometimes, like exenatide, you have to give them BD, or like liraglutide, you can give them once a day. Now, what I also want to show in this is the size of the molecule. most of the molecules, you can see exenatide, lira, sema, exenatide, are all small molecules, whereas dula and albuglutide are huge molecules. Look at the size. They are like 20 times bigger than the other molecules. Now, does it have an importance? Yes, it does. Because the GLP-1 receptor analogs, the large molecular size, do not cross the blood-brain barrier and may not have access to the satiety center. So, therefore, they have less weight loss benefits. Now, has the last word been said about the incretin therapies? Guess again, no, it hasn't. So, first of all, it took us 60 to 100 years before the concept became a reality. The proof of concept became a reality. Then, 1984, GLP-1 was discovered. And then we have the GLP-1 receptor analog. Took 13 years for these compounds to come out. And then it was once daily, twice daily. Then came the once weekly, which was also quite popular, as you know. Then came the oral, and this is the breakthrough which we are celebrating today, and we'll talk more about that. This is truly a breakthrough. It is a miracle as far as pharmacology is concerned. I'll talk about that. But we're also going to have, as we go forward, combinations of these coming, co-agonists coming, and who knows in the future what else is going to come. So we are living in very exciting times, ladies and gentlemen, where we're going to see innovations after innovation coming, all improving the lives of people with diabetes. And is it just diabetes that it benefits? No. It's also used now as a separate indication for obesity, and for people with obese type 2 diabetes, obviously it's becoming a drug of choice now, at least for those who can afford it. Type 2 diabetes, it covers almost all the beneficial effects that you would expect for type 2 diabetes. Atherosclerotic cardiovascular disease, for preventing it, we know that most of the drugs are neutral, but there are others which are shown beneficial effects, including semaglutide, liraglutide, and so on. Therefore, CV risk reduction is a big, big plus point with these drugs. Of course, it also improves lipid metabolism, reduces inflammation, reduces NASH. We might soon see that these drugs being prescribed separately for NASH, which is going to become a major killer these days because it's turning into cirrhosis and hepatocellular carcinoma. So we're seeing a different syndrome coming there, and this may be one of the drugs which is used. And of course, Alzheimer's and others where studies are going on. So to summarize, therefore, this part of my talk, I have one more little later. The history of incretins is very interesting that they preceded insulin. Not many people know that, but somehow the development was very slow and it took long time. But today, the fruits of those researchers, the research that they did is being paid off, and we're beginning to see the benefits. The development has evolved from the short-acting to the long-acting molecules, from injectables to oral preparations. This oral thing is something I think which is a real breakthrough, no doubt about it at all. And I have no hesitation in saying that this molecule being the first peptide in a pill, nobody thought that a peptide can come in a pill. I would not be surprised if the Nobel Prize is given for the development of this molecule. In fact, it's my prediction, mark my words, that this production of a pill in a peptide form, a peptide coming as a pill, certainly deserves a Nobel Prize. And I would be very surprised. In fact, one of the Nobel Prize committee members was talking to me, and I was saying you should seriously consider this because they take long time before they evaluate these, and it's a very slow process. But it is that kind of it's almost like the discovery of insulin, because who knows that the knowledge that we learn from this may ultimately lead to insulin being delivered orally. We have made many attempts, Novo has made many attempts, Biocon has made many attempts, but we have failed so far because of the bioavailability. But today, if we can improve the bioavailability from the lessons learned, and the research is still going on, maybe insulin will come in oral form. And if that happens, you can imagine what a big breakthrough it will be. And therefore, today we have the potential not only to apply this for treatment of type 2 diabetes patients, but also obesity, NASH, and cardiovascular disease, certainly. So we are in for very exciting times. And I'd like to thank you. And we have two speakers after me who will be talking about the evidence. We have said all this now, but I have not given you any evidence. The actual evidence from the CVOT trials are going to come from the next two brilliant speakers to follow. So over to Shashank again. Thank you very much.
Thank you very much, Professor Mohan sir, for a wonderful lecture on the history of incretins and the GLP-1 RAs. For our next talk on revisiting the birth and journey of CVOTs, a GLP-1 RA perspective, we have with us Dr. Srirang Godbole, who is an eminent endocrinologist, Director Institute for Treatment and Research in Diabetes in Stride, Pune, and also the Director of Endocrine Laboratory, Pune, and Consultant Endocrinologist at Jahangir Hospital, Pune, and also regional faculty for many CCBDM and Public Health Foundation of India, and also for Dr. Mohan's Diabetes Education Academy. And sir has published many books and publications into his account. And Dr. Sir has received Dr. S.N. Cooper Award Oration, Moscone, Pune, and also Baliram Dubey Award Oration, Indian Medical Association from Nagpur. And sir also a regular contributor to Madhumitra bi-monthly Journal of Diabetic Association of India for the Pune branch. And sir has contributed several articles on diabetes and endocrinology in Daily, Sakal, and in Pune, and also has delivered lectures on growth and development on Akashvani Pune Kendra. And sir has been principal investigator and co-investigator in several multi-centric phase 2, 3, 4 trials in diabetes and endocrinology. With this brief introduction, I hand over to you.
Thank you so much. At the outset, I must thank the Indian Academy of Diabetes and Novo Nordisk for this opportunity. And over the next 10 minutes, I shall revisit the birth and the journey of CV outcome trials, especially from a GLP-1 receptor agonist perspective. Can you move? Just move forward. Okay. Now, what data I'm showing you is actually from the Caliber program, which involved some 1.9 million people, of whom 1.8% had type 2 diabetes. And the Caliber program actually integrates data from 4 different electronic databases in the UK. And what the investigators were trying to find is the association of diabetes with incident cardiovascular disease. And they had a whole list of 12 cardiovascular diseases. And they found out that people with diabetes are at a 53% increased risk for unstable angina, a 54% increased risk for myocardial infarction, 56% increased risk of heart failure, and a 72% increase in the risk of stroke. And for every 1% increase in the A1C, there was a 28% increase in peripheral arterial disease. So heart disease is the cause of death in more than 2/3 of people with diabetes who are aged 65 years or older. So it is the cardiovascular disease which probably kills more than any other cause in diabetes. So we thought, well, diabetes causes micro and macrovascular complications. So we intuitively thought that if we control diabetes well, we might as well also prevent micro and macrovascular complications. This was the thinking. And prior to the CV outcome trial era, these were the 4 landmark trials in type 2 diabetes. You had the UKPDS in treatment naive type 2 diabetic patients, and then you had the advanced VAT and the ACCORD trials in fairly chronic diabetic patients. And the aim was to, randomize patients to an intensive arm and a conventional arm, try to get down the A1C as low as possible. In fact, in ACCORD, it was targeted at less than 6.5. But really, the data showed that at the most, the evidence that good glycemic control holds true for microvascular complications. The data was still not very unequivocal for macrovascular complications. The data then started appearing later when these trials went on to their extension period. So the relation between tight glycemic control and macrovascular complication prevention was not very clear. And the one thought was, is it actually the drugs that we use in type 2 diabetes which actually increase macrovascular disease risk? And that is why we are not getting that sort of unequivocal results. So prior to the CV outcome trial era, you had some conclusions which we were drawing. The DCCT and the UKPDS taught us that it's important to treat patients early because these were treatment naive patients in the UKPDS, and you ought to treat to target for microvascular benefits. But then the ACCORD, ADVANCE, and the VAT trials, because the ACCORD had to be stopped because the patients in the intensive arm actually died more. So then the thinking was, no, you can't have a one-size-fit-all HbA1c target. You need to individualize the HbA1c target to avoid harmful cardiovascular outcomes. And then you had the follow-up of the DCCT trial in the form of the EDIC and the post-UKPDS, which taught us that macrovascular benefits may take a longer time to manifest themselves. You need to go long-term to get those sort of benefits, and that too if you have started treating well early on in the course of the disease and established a good glycemic legacy. So after metformin, this is how, type 2 diabetes management has evolved on a background of healthy behavioral interventions and multifactorial risk factor modifications. Prior to 2000, all we had was sulfonylureas, insulin, and metformin. And we thought, well, lower the A1C, the better it is. Then between 2000 to 2014, you had the TZDs, the DPP-4 inhibitors, and some of the GLP-1 receptor agonists. And then we learned that lower the HbA1c may not hold true that it's better for all. We also need to avoid hypoglycemia. We need to avoid weight gain. And then 2015 onwards, we have seen a rapid development in the GLP-1 receptor agonist space, and also the introduction of SGLT2 inhibitors. And now we know that we need to individualize HbA1c targets depending on the patient profile. We certainly need to avoid hypoglycemia and weight gain. And also, if possible, we need to reduce MACE, heart failure, and chronic kidney disease complications. The challenge always is, how do you implement clinical guidelines into the reality of clinical practice? How do we bridge the gap? And I think the key to that is to learn more and more. How did CV outcome trial start? We all know that this mandate from the US FDA came in 2008 following the meta-analysis that was published in the NEJM by Nissen et al. Involving a study of about 42 fairly small-sized clinical trials involving rosiglitazone. And what they said that, following the meta-analysis, that there's an increase by about 43%, which was statistically significant, in the risk of myocardial infarction, and a non-statistically significant 64% increase in the risk of death from cardiovascular causes. And then the US FDA said that if you want to introduce a new anti-diabetic drug in the market, you first prove that it doesn't produce an excess cardiovascular risk. This is how the CV outcome trials started. And we know that prior to the CV outcome trials, all that a new anti-diabetic drug had to do was to document HbA1c lowering over a period of, say, 6 months or maybe maximum 1 year. These were short-term trials. All you had to just demonstrate was an HbA1c lowering. You also, of course, had to demonstrate safety. But you had to exclude high-risk populations. You had to exclude people with cardiovascular disease, renal disease, and you just completed the trial in 6 months to a year. And it was the investigator who reported the cardiovascular events. This all changed with the US FDA mandate. Now you had to prove that a new anti-diabetic drug did not produce increased cardiovascular risk. You, in fact, had to now include high-risk populations, especially those with prior cardiovascular disease, renal disease. You had to have long-term data for at least 2 years, and you had to have a prospective independent adjudication of cardiovascular events. And of course, there were various statistical endpoints, pre-approval, post-approval. The 95th percent upper boundary had to be 1.3 post-marketing, less than 1.8 pre-marketing. And then came the CV outcome trials, and these were event-driven trials which were designed to establish non-inferiority, just safety for the 3-point MACE. And the initial CV outcome trials, starting with the SAVOR-TIMI and the EXAMINE trials, and also the TCOS and the ELIXA for lixisenatide, all met their primary endpoint of non-inferiority. Of course, the SAVOR-TIMI did show some increase in hospitalization for heart failure, which was also to some extent duplicated by the EXAMINE, but thankfully the TCOS laid that fear to rest, at least with sitagliptin. Lixisenatide also showed non-inferiority. So these were the initial CV outcome trials. And then came the exciting times in 2015, 2016. We were aiming for non-inferiority, but now came 2 drugs initially, the leader, the liraglutide, and the empagliflozin trials, not just showed non-inferiority, but actually benefit for the 3-point MACE, and a similar sort of benefit was also seen with once-a-week semaglutide. So these were the 3 trials which actually showed benefit. And then subsequently you had a number of trials. Now mark you, the CV outcome trials were not meant for insulin, but nevertheless the DEVOTE trial did compare degludec with glargine and showed a non-inferiority. You had the CANVAS program, which showed superiority to some extent, and then the exenatide trial again showing non-inferiority. And then you had the Harmony outcome trial with albiglutide, which is of course not available. And then you had Carmelina for linagliptin and declaratimine with dapagliflozin, again showing non-inferiority. And then the REWIND trial came, very exciting trial, because the first trial to show benefit actually not just in a secondary prevention cohort, but actually in patients with multiple cardiovascular risk factors. The Carolina trial, important because it had 2 active comparators, and then the Pioneer 6, which I'm sure we'll be listening to in greater detail. So naturally, all these things came into the new guidelines, and so it's now clear that in patients with established atherosclerotic cardiovascular disease, you use a GLP-1 receptor agonist or an SGLT2 inhibitor with proven benefit, and not just for established disease, but even for MACE prevention, you can use these 2 classes of agents. Well, all diabetics virtually are either high risk or very high risk. There's nothing like low risk in diabetes. Very few are at moderate risk, but it's either high risk or very high risk. And you use one of these 2 agents, the GLP-1 receptor agonist or the SGLT2 inhibitor, and then irrespective of entry-level A1C or the target A1C, and then you then move on to the other agents. So this is how guidelines evolved. In 2019, remember, ASCVD predominates, use a GLP-1 receptor agonist or an SGLT2 inhibitor if EGFR adequate. No, in 2021, that EGFR thing goes out, because now, in fact, lower the EGFR, maybe you'll help the patient more. And similar are the ESC guidelines and the ACC 2020 guidelines. So it's both for MACE prevention as well as for established atherosclerotic cardiovascular disease. So this is the current pharmacological armamentarium. And Dr. Mohan alluded to the fact that initially our approach was glucocentric, and now with the introduction of these exciting new molecules, we now have a cardioglucocentric, and I would say a cardio-reno-glucocentric approach. And that has resulted in a dramatic reduction in morbidity and mortality. And type 2 diabetes, we talked of dirty dozen, multifactorial causes, and that will need multifactorial intervention. So prior to 2008, the concept was lower the A1C, the better it is. In 2008, following the US FDA mandate, lower the better HbA1c, fine, but without the weight gain, the hypoglycemia, and the side effects. And now we know that we have to reduce cardiovascular risk, we have to address blood pressure, LDL, cholesterol, and we need to use glucose-lowering agents with proven safety and efficacy. Thank you so much for your patient hearing and attention.
Full lecture on the journey of CVOTs and especially envisioning us on the GLP-1 RS effects. To give us the next lecture, we have Dr. Sunil M. Jain with us, and who is going to speak about the GLP-1 RA class spreading its wing beyond diabetes. So as you all know, Dr. Sunil M. Jain, he has a vast experience of more than 30 years, and he is the director of, Center Director of RSSTA Accredited Institute, and also Center Director of for India Diabetes Educator Project, and faculty for practical guidance on comprehensive diabetes management, and author of several publications in the field of diabetes and various national and international journals, and also in newspapers and diabetes educational videos. And sir has delivered many lectures as a faculty in national and international congresses, and engaged in number of clinical trials in Total Research Center Indore, and the Total Diabetes Hormone Institute was envisaged to fulfill these objectives of research and education, and author of Madhumeh Ek Naya Jeevan Saathi, and also author of How to Get the Most Out of Your Pump, and also the chief editor of website www.diabeteshormone.com. With this brief introduction, I hand it over to Dr. Sunil M. Jain.
So thanks, Dr. Vijaya and Indian Academy of Diabetes and Novo Nordisk for inviting me. And I am going to talk in next 10 minutes on GLP-1 receptor agonist and what are the newer possibilities which are coming up. when it was talked about where the GLP-1 acts in our body, already Dr. Mohan has given you an idea, and that is what I am going to talk in terms of therapeutics. And we know that oral semaglutide, we are going to discuss is further about its oral bioavailability, DPP-4 stability, a very long half-life. But the major issue, we started development of these therapeutics primarily for the management of diabetes. That's how it started. Then slowly we understood that this class of drug, apart from diabetes, is a good drug for weight management as well. And that's how the obesity component added. Then Dr. Srirang talked about the cardiovascular outcome trial, and when the data came, then we understood that, okay, this is the class of drug where there is a evidence-based information for cardiovascular disease benefits. And then now we are getting more and more additional information from the newer researches which are coming to us. And that's how now we know that apart from diabetes and obesity, where now it is a labeled indication, cardiovascular disease, we know all the guidelines talk about using GLP-1 receptor agonist in patients with high risk for cardiovascular disease or existing cardiovascular disease. But now the next area is chronic kidney disease, non-alcoholic steatohepatitis or NASH, which was talked about, Alzheimer's disease, etc., etc. And is there a possibility of a pharmacotherapeutic intervention with the drugs of this class? And that's what I'm going to discuss. And there, let me quickly talk about NAFLD. We understand what is NAFLD, how it initiates, and a big role of insulin resistance in the development of NAFLD, because we know that in the states of insulin resistance, at one end there is an increased lipolysis and more fatty acid traffic flow to the liver, and on other end there is an increased de novo lipid synthesis happening inside the liver, and that's how it initiates. So it's basically a process which initiates with insulin resistance with multiple comorbidities. And there, in insulin resistance, the obesity and central obesity plays a big role. And that's how, if we do something which apart from bringing glucose can reduce central fat, can reduce obesity, can reduce other comorbidities, then it is going to have a benefit. And that's how is the logic and a rationale behind GLP-1 based therapies for NASH. And here, it is expected that by causing weight loss, it is going to have a benefit that was obvious. But now additional learning is GLP-1 has shown to reduce the hepatic fat content and reduce the inflammation. And that's how this is a new era which has started. And there we have some clinical trial data. This is the 200 patients, roughly information, where injectable semaglutide in a variable dose, you can see here 0.1, 0.2, and 0.4 mg versus placebo. This was given on daily basis. And they tried to analyze what is the effect on NASH and what is the effect on liver fibrosis. And we saw that with a dose of 0.4 milligram, there is a quite significant reduction in steatohepatitis, and that's how there is a reduction in liver fibrosis, and that's what was observed in a study which was having a reasonably long duration. And this was expected to have a reduction in body weight and hsCRP. So in brief, if we compare with placebo, though there is no recommendation as such today for using GLP-1 receptor agonists for the treatment or management of NASH, but there is a guidance now that yes, there is a possibility that the GLP-1 receptor agonist, and I have shown you the trial data of injectable semaglutide, which might be a promising molecule in the field of NASH management, which is becoming a very big issue nowadays. The second very interesting area, because if we try to understand the brain glucose metabolism, there are a lot of complexity in this zone. And we know that the dementia, cognitive dysfunction, Alzheimer's disease, they all have one feature, that is the glucose hypometabolism and a lot of inflammatory process, synapse level things, so many things happening here. And can GLP-1 receptor agonist play a role here? And it is interesting that in the clinical trials like LEADER, PIONEER, and SUSTAIN trial, when they just did a post hoc analysis, it was observed that the patient who were in GLP-1 arm, that is, who were on liraglutide or injectable or oral semaglutide versus placebo, the incidence of dementia was higher in placebo as compared to GLP-1 receptor agonist. That means we have a good evidence-based information from long trials, and that's how the thought came for any possibility of GLP-1 receptor agonist in future in Alzheimer's disease. And we know that there are receptors present in the brain, on neuroglial cells, on astrocytes, on neurons for GLP-1. What they are doing there, we are understanding, and very importantly, it is shown that if we are using GLP-1 receptor agonist, there is increase in glucose metabolism, an improvement in the glucose metabolism. And this is ATN, that is amyloid deposition, tau deposition, and neurodegeneration. These are all taken care when patients are receiving GLP-1 receptor agonist therapy. And look at this, EVOKE and EVOKE Plus. These are the two very large trials in which 3,680 patients are getting randomized. And these trials are going to find out whether the drug like oral semaglutide or semaglutide can help in delaying dementia and Alzheimer's disease. So this is another big area apart from NASH, and that's what is going on. And the third area, which heart failure, or now in heart failure, we talked a lot about the heart failure with reduced ejection fraction, and we were a bit concerned about what will happen to the diastolic heart failure, the new term for which is now we call it heart failure with preserved ejection fraction. And here we understand that there is a adiposity heart connection, and that's an important background that insulin resistance, adiposity, and many cytokines play a big role in heart failure with preserved ejection fraction. And that's how this new area now getting further evolved, that what will be the role of therapies which are going to cause a good weight loss, reduce inflammation, work on adipocytokines and their role in heart failure with preserved ejection fraction. And we know these are all the effects of GLP-1 receptor agonist, and that's how this is a very potential possibilities for future that these drugs may be effective not only in treatment of diabetes, but also in preventing morbidities associated with heart failure with preserved ejection fraction. And that's how work is going on. We have some indirect evidences right now in form of cardiovascular outcome trials and cardiovascular benefit with liraglutide and semaglutide. So that's how these are the drugs which are working into multiple pathways, multiple mechanisms, and carry a big potential for multi-therapeutic indications. And that's what you can see. So as we were talking earlier, that was the era of insulin therapy and the drugs which are working through pancreas and other zones, and now you can see that the next pipeline is working primarily on the GLP-1 based therapy, weight management area, and that's how these are the type 2 diabetes. You know, semaglutide injectable is now recently approved for a dose of 2 milligram. Then icosema, that is a once a week insulin and once a week injectable semaglutide, it's already there in pipeline. And a dual acting peptide kind of thing with GLP-1 and GIP, and now oral semaglutide, and the trials are on to use it, this semaglutide Rybelsus up to 50 milligram per day. That's what is into the trial. And you can see this is the obesity pipeline. Again, a lot of role of GLP-1 based therapy and some other molecules, including GDF-15 and amylin analog, etc. and PYY. So a lot of things are happening into this area of obesity, because we understand that in obesity we had few drugs, and now they are working on certain drugs which are going to work for cardiovascular disease management through taking care of lipid parameters, and NASH and Alzheimer's disease I already talked about. So that's what is the expanding landscape for GLP-1 receptor agonist-based therapies. And that's what is a great and new learning for us with a very big promising future. Thank you very much.
Thank you so much, Dr. Jain. We now come to the much awaited talk for the day, which is the Novo Nordisk Game Changer Symposium. And we have a researcher and innovator with us, a very old friend of mine, Dr. Anil Shinde. He's a senior director of the clinical medical research for Novo Nordisk Southeast Asia. He has more than 30 years experience in the pharmaceutical industry. He's very much from Maharashtra. He's a graduate and postgraduate from the Aurangabad Medical College. He has lived in Novo Nordisk in multiple continents, whether it is Asia, Middle East, Europe, and Africa. In the past, he has worked with various other global and Indian companies, including Pharmacia, Dr. Reddy's, Alembic. He's a professionally qualified clinical pharmacologist. He is a member of the ISCR, IMA, EFPA, and he's involved very closely with drug development, medical education, and regulatory affairs. So Anil is going to really tell us the whole story which Dr. Mohan highlighted may be a game-changing story, maybe a Nobel Prize winning story of this whole molecule which we are going to unveil today. Dr. Anil Shinde.
Thank you. So thank you very much, sir, for a nice introduction, and thanks, Dr. Mohan, setting the scene, and Dr. Sunil M. Jain and Dr. Shri Godbole for setting the scene for this, my presentation. In the next 10 to 15 minutes, I'm going to talk about the very important aspect of Novo Nordisk and how we have made this possible oral formulation of Rybelsus or the oral semaglutide in our market. So this slide shows the Novo Nordisk at a glance. I think all of you are sitting here. I think once again, I'd like to extend warm welcome to all distinguished faculty from India, as well as the physicians, those who are interested for this talk, today's meeting, extending warm welcome to all participants, and wish you once again the Happy New Year, Happy Gudi Padwa to all the Maharashtrian friends sitting in this room. So Novo Nordisk is more than close to 100-year-old company. It's founded in 1923. As you heard from the earlier speakers, I think we are worldwide present everywhere, and our purpose of Novo Nordisk is to defeat diabetes and as well as drive change in the other chronic diseases. And I think these numbers are exemplary for you to understand, but I would like to talk to one point. Every alternate patient is on a Novo Nordisk insulin. I think that's a huge responsibility on Novo Nordisk products which we are bringing to the market. It's not only diabetes care company. We are known for bringing innovative molecules in obesity. We are also made a good progress in rare endocrine disorder, as well as rare blooding disorder, as well as some other chronic diseases. So how we are going to make this possible? The driving change together with science and innovation. I think this is very exciting time to be part of Novo Nordisk, as well as in a diabetes care, as well as in some chronic diseases like which are shown here. The first bubbles which showed therapy area, which comprises diabetes, obesity. There's a huge, the size of the bubble indicates our innovative molecules coming into the pipeline and already made some progress. And the smaller bubbles, the chronic kidney disease, as well as cardiovascular disease, as well as NASH or the brain disorder. They are relatively smaller molecules, but we have made a significant progress. In terms of our focus, how we are bringing innovative molecule, name it insulin or is GLP-1 or some other innovative molecule that Dr. Sunil M. Jain has talked about those innovative molecules. So we raise the bar of innovation by bringing the products you have seen, the innovative insulin, which when it is launched in the market, from animal stores to analog to the once a day to once a week also is coming up, and that's how we bring the innovation. And also expansion into the newer therapy area. And how all those innovations are bringing, it's a technology platform of protein engineering, and that's what it is, a continuously develop newer and newer protein and newer innovative mode of administration of the innovative products in India as well as worldwide. How we do in Novo Nordisk, and it's extremely important all of us to know about this. Novo has a deep understanding of protein manufacturing and protein synthesis and protein co-formulation of the different formulation. Also, we have disease understanding with the key opinion leaders sitting in this room, and we work with all over world with different key opinion leaders. We have great understanding of the different chronic diseases. And also we have the patient understanding in terms of what patient needs, and that's what is a combination of the protein engineering plus disease understanding as well as the patient understanding or the patient unmet need all combines with that, how we can bring the innovative molecules. And I think we have made a significant progress in terms of innovation in insulin, and we have a tremendous pride about this development. Since the Banting and Best discovery of insulin, and that the journey of insulin discovery is continuous. And I think we have made a significant progress from discovery of insulin to manufacturing of insulin and bringing innovative molecules like analog, the second generation analog, as well as now we are developing once a week analog insulin. We are also developing hepatic specific insulin also is under development, as well as the oral insulin, as well as the glucose sensitive insulin. There will be insulin in the future. There could be possibility of hypoglycemia will be minimum in the patients of and that's and the future of insulin replacement is the beta cell replacement. And as incretin therapy expanding, and Dr. Mohan has explained it quite well, and also Dr. Sunil M. Jain also talked about this. But I would like to talk only one point, that last 4 decades of GLP-1 discovery, it's a relentless research and innovation is progressing in the right direction. And we are talking about the indication expansion, and we heard the different studies being presented here. It could be NASH, it could be Alzheimer's disease, it could be cardiovascular diseases, and that can become a kind of the indication. The research work is going on in this direction on this. So what is the protein needs to be administered injectably, and how we can make it possible and how we can improve patients' outcome. The injection is a barrier for most of the millions of the patients across the world. And the treatment initiation is a barrier because the physician needs much longer time for the explaining to the patients how to take, how to administer. The treatment adherence is a problem, is a compliance issue, and how to have the optimal control for our patients. And that's why the Novo Nordisk progress in terms of bringing this peptide in a pill formulation. The holy grail of protein engineering, the protein chemistry, peptide could be delivered orally. And that's an extensive research. The last 15 to 20 years of the research, innovation which you have worked together with the scientists and the key opinion leaders across the world, and oral semaglutide, the game changer and the life changer innovation. And it is an example of transformational research which has happened, and it is unheard of the protein and the peptide getting into the pill formulation, and which can make a life better for all this. How it has, Dr. Mohan is going to talk about in detail in the subsequent presentation, but I will talk about is a peptide, the semaglutide. It was possible to combine with the semaglutide with a SNAC. SNAC is nothing but sodium N-hydroxybenzyl aminocaprylate. So you don't have to remember the long form of the SNAC. It is a SNAC, is a short form of, is a small chain fatty acid which combine with the semaglutide and which can facilitate absorption, and it also increases the pH in the stomach, and thereby the peptide is possible. As we are talking, it's a very simple formulation, but it's not as simple because the research, the continuous research of the 20 years, and this is made possible to bring this innovation. And also this is tested in a different kind of diabetic progression disease, as well as different kind of continuation of the type 2 diabetes management, empagliflozin, sitagliptin, as well as insulin add-on, as well as liraglutide, as well as dulaglutide. And the development program of oral semaglutide was named as a pioneer program, peptide innovation in early diabetes treatment. We want to offer the benefit of this peptide innovation in a patients with the type 2 diabetes patient, a semaglutide in oral formulation we can start at early stage of the diabetes development, the Pioneer 1 to Pioneer 10, the different studies were conducted. And this was one of the biggest development program which conducted by Novo Nordisk, close to 10,000 patients. And some of you are part of this developmental program and you have witnessed this fantastic experience with this product. And the peptide in a pill diabetes is in this management of the type 2 diabetes is a game changer development, and is a game changer as well as life changer is born here, and that's why all of us are assembled here. So game changer and the life changer peptide in a pill and Rybelsus. So I request the team to show the introduction of the Rybelsus launch video, and subsequently we'll have the presentation by other speakers.
There's a silent killer plaguing humanity. It strikes indiscriminately and viciously. No, it is not a new virus. It has been known for centuries. Ancient scholars called it Madhumeh. Today, we call it diabetes. In 1922, the first insulin injection was administered, and it allowed people to lead normal lives. But it meant that patients were facing the needle every day. And sadly, over the last 100 years, very little has changed. Today, an estimated 77 million Indians are living with diabetes, and this number will double in the next 25 years. Diabetes increases complications like myocardial infarction, stroke, and heart failure. 70% of people living with diabetes are overweight or obese. The problem of complications increases with overweight or obesity. We desperately need a painless 21st century solution. A game changer that not only controls blood sugar, but also reduces weight and mitigates cardiometabolic risk factors. It's time to reach out to a new dawn. It's time to touch the future. It's time to look at the new possibilities. And now, we welcome the rebel, Rybelsus, the world's first and only oral GLP-1 RA option for type 2 diabetes. Rybelsus is an elegant solution that simultaneously works on blood sugar, weight loss, and cardiovascular health. Rybelsus offers unprecedented HbA1c reductions, unsurpassed weight loss, consistent CV safety, and reduction in other cardiometabolic risk factors. And when all three factors unite, you get Rybelsus. A game changer, a life changer.
Thank you very much. I request all the eminent faculty, Dr. Shashank Joshi, Dr. V. Mohan, Dr. A.K. Das, Dr. Anil sir, and we have a special guest also, Dr. Harish Shetty, all to come over the stage and speak one sentence about the new game changer, life changer, Rebelsis. And also Dr. Rajesh Rajput, Dr. Arpan Dev, please come over to the dais. Dr. Sunil M. Jain, Dr. Amaya Joshi, Dr. Om Lakhani, Dr. Jugal Garda, Hemant Fatale, sir. So please come over the stage.
Hello, hi, how are you? Hello, hello. I'm seeing all the programs. They're having one from here now. Yeah, I know, I heard. Okay, you want me to go first? You already said everything in the video, so there's nothing more to say. I think it's really a game changer, and I think it fulfills all the dreams of people with diabetes. You couldn't have asked for anything better. Congratulations to Novo.
Shall I? Research has benefited mankind always. I hope and I feel that this will also.
Peptide in a pill, it opens a magic box. It has many more implications beyond the GLP-1.
It's the pill of this decade.
A game changer, a life changer. So a game changer, life changer molecule of probably this century.
I remember Bikrant, who is not here today. He expressed during National Insulin Summit that Novo Nordisk is not only a company which brings in drugs, but brings in science, innovations. They live, they work, they breathe for bringing newer and newer molecules. Prescribe and perceive the difference.
I think good luck very much. All of us, you need to get some experience on our patient using this. We have just started using 3 milligram, 7 milligram with very good response.
Yeah, I agree. It is going to be a trump card in management of type 2 diabetes and obesity.
I think we are going to see a paradigm shift in not only type 2 diabetes management, but overall obesity management as well. I think, remember this event today, because I think this is perhaps a very important event in terms of the way we think of diabetes in the next decade. So I think that's the game changer.
I think it's going to be not just diabetes and obesity, as they've told, it'll be Alzheimer's. So we're going to have a lot of more applications for this. And as V. Mohan sir rightly said, probably it can definitely win the Nobel Prize in the next year or so. Thank you.
We have a popularity contest and we all vote, I think we'll get it.
Mangis.
Yes.
Well, thank you very much. We all know that this has been one of the new sensations which has come. What is most interestingly is this is one of the probably the first kind of intervention which has been so accepted so quickly and has started also showing an impact as far as the management of diabetes or the related challenges are concerned. So congratulations everybody.
Thank you. Thank you. So thank you everybody, and let's move on to the next talk. Thank you so much. Thank you Novo Nordisk for getting this molecule here. Can I have this stage up here? And Professor Mohan, you could be very much here because he's now going to really tell us how this molecule was born.
One more, Srireka, no, it's changed. Oh, next.
So from idea to reality, the birth of the first oral GLP-1 receptor agent, Professor V. Mohan. You know that Professor V. Mohan needs no introduction. His H index is the highest from any medical scientist in this part of Earth and probably the world. And he's in the top 10 scientists on planet Earth in any specialty. So please put your hands together for Professor V. Mohan.
Got it? Where's the Anil, you have the changer with you? So I know we are slightly behind time, so let's get straight on. There is a brilliant way of launching this molecule, by the way, and it deserves all the acronyms, accolades, and everything that we have given it without any doubt, straight from the heart. So we have been already speaking about GLP-1 receptor analogs, and Dr. Anil Shinde already mentioned something about this molecule, semaglutide, which is the first oral GLP-1 receptor analog. So a little bit more granularity into this molecule. Now, you all know that if you gave a choice to patients about a vial and a syringe and then a once daily pen injection, that will be the order in which people will go. Okay, pen is better than syringe. Why? Because you have to carry it, you have to refrigerate it, you have to do all kinds of things. They'll think you're a drug addict. All these kind of problems are there with the first one. Second one, pen. Okay, a little more stylish. You don't, don't carry your disease with you. You don't advertise it so much. But then when once weekly things came and GLP-1 RAs, they were popular. There's no doubt that once weekly. In fact, just casually I started telling people that once weekly insulin is going to come. You should see the number of people who are writing to me. And I feel bad because type 1s think that one injection in a week is enough. And I don't have the heart to tell them that, no, you'll still need your, the bolus doses you'll still need. But even the very mention of once weekly insulin, once weekly, this is going to be a game changer, and then just keep quiet. Maybe, who knows? Maybe something like that may come. Science, whatever you thought is impossible is happening. And from there to oral, I mean, just imagine if oral insulin is produced. Anyone in this room doubts that you won't get a Nobel Prize for it? 100%, probably next year itself, just like insulin was given. Incidentally, you know that insulin's Nobel Prize within 1 year is the only time Nobel Prize was ever given within a year. Never before or never after it has happened. So that's where we are going, and that's why it's very exciting. So we are not just saying this because of an OO meeting and we have to say all these things. It's really true. What you're going through is history. As Dr. Lakani said, I think you should remember this event because we're creating history. Right. Now, why is this reluctance to take an injectable therapy, particularly insulin, but also for any injectable therapy? Of course, with insulin, people have a feeling that it's my last days have come, because they would have seen somebody being given insulin when they're about to die in the hospital and they took the insulin. So anytime I start, so it's over, doctor, my days are all over, numbered and all that. So that's how they start off. But any injection every day, people don't like that. Same thing, you give them a vitamin injection, they're willing to take it. Tell them a vitamin injection once a week and they're willing to take it, but not these kind of, people's psychology is very difficult to understand. So fear of injection, this last resort thing, fear of hypoglycemia, it's a true fear. We can't get away from that. Too many injections, fear of weight gain, of course, with the insulin particularly, but not with the GLPs, and poor communication with physicians. We are also partly to blame. Now what we do, next time your sugar is not controlled, I'll put you on insulin, as if it's like I'm going to thrash you kind of a thing, We have been saying that too many times, and so people think, oh, that's the kind of punishment I'm going to get, So, of course, the statistics show that anybody would prefer a tablet. You and I would prefer a tablet. Come on, let's face it. If we are given a choice, you want to take an injection every day or you take a tablet, we'll all grab the tablet before God changes his mind. So, oral insulin and GLP, we have gone through this. It's interesting, I was just asking at the beginning of this meeting, is it true that oral insulin was tried before in the 1920s? Apparently it was true. They first tried oral insulin and then they didn't even give up. They still tried emulsification of that, oral enhancers, first proteases without emulsion, liposome, all kinds of things have been tried. But with insulin, we haven't succeeded so far. Main problem is not side effect, it's bioavailability. Only about 1% is absorbed, or less than 1% is absorbed, which means that your dose of insulin is going to go up more than 100 times. So if you're taking 40 units, you'll end up with 4,000 units. Imagine the cost, apart from everything else. And it's not even absorbed in the same manner every time. So these things have been going on, but with GLPs have beaten insulin as far as the oral route is concerned. So the quest for the oral peptides is also challenging. Why? Because of three problems. One is enzymatic degradation. We have this thing called hydrochloric acid in the stomach. Anything put into that will be bush, gone. It will be destroyed. Any peptide which you put there will be destroyed immediately. And then you've got limited permeability. It's not able to permeate and go inside. And then low bioavailability. It has to get absorbed. If it's all destroyed there by the hydrochloric acid, what is going to think? So then you have to get rid of these things. You must find proper enzyme stability and then permeability and avoid the food effect as well. So where the GLP-1s have scored over insulin is, if you can debate that, in fact, you can have a good debate whether insulin should be started first or GLP-1 receptor analog. I'm sure both of you, whoever's arguing, can put forth equally good points. But GLP-1s have certain advantages. Insulin, there is no fixed dose. You have to keep adjusting the dose. Yeah, it's a fixed dose. Whatever you give, it's a fixed dose, oral or whatever. You might titrate it, but finally you're ending with one dose. Multiple benefits, pleiotropic effect, you may say that insulin also has it, but GLP-1 seems to go a little beyond that. Most important thing is no hypoglycemia and no weight gain, in fact weight reduction. That you cannot say with insulin at all. Those are definitely a drawback as far as insulin is a hormone, it's an anabolic hormone, it will increase your weight. Plus, and all this is possible because it's a smaller molecule, longer half-life, and addresses multiple defects of the body in type 2 diabetes. So why do we really need this oral GLP-1 receptor analogs? Because poor glycemic control, all of us have inertia in treating diabetes and we keep delaying it. So if you have a molecule which works and orally, definitely you can overcome that inertia. Treatment intensification by adding this is much easier. Now, of course, they've stood the test of time in terms of efficacy and safety, and oral semaglutide has now arrived. Now, the foundation stone for oral GLP-1 receptor analog semaglutide, three things were done. The first is that the amino acid substitution at position 8, which protects against DPP-4 mediated degradation. So once that was changed, the first advance. Second is that at position 34, the amino acid substitution prevents the C18 fatty acid binding at the wrong site. And then the spacer, the C18 fatty diacid. In fact, very interesting because for most of Novo's innovations, fatty acids have been used. Strangely, no other company seems to be using that. Novo somehow got on, they've understood this chemistry of this fatty acid so well. And so this helped. And also it's useful that semaglutide has 94% homology with human GLP-1. This slide you have seen ad nauseum. I'm not going to spend time on that because the GLP-1 receptor analogs, many of the other oral anti-diabetic drugs that we know of, sulfonylureas, metformin, just reduce the sugar. What more? Of course, metformin, you may argue, gives you something more. Sulfonylureas don't give you anything more other than reducing your glucose. But here we're talking about a drug, one molecule with multiple mechanisms, diabetes, obesity, cardiovascular disease, NASH, chronic kidney disease, Alzheimer's disease, emerging that so many benefits for one molecule, probably all of us should take it, even if we don't have diabetes, just joking. So now you talk about permeation enhancers, proteolytic inhibitors, and so on. So therefore, you have synergy, and it's also quite simple. And that's where the innovation went to the next level, and the oral development of the oral semaglutide came. And this impossible thing to pronounce snack was the key. And once snack which was discovered, then everything else fell into place. How come? Because this is how it works. So as a tablet erodes, snack causes a transient increase in the pH, and that's very important, protecting semaglutide from the proteolytic degradation. Remember I mentioned about hydrochloric acid and so on. So there you are getting rid of that. The second thing is it facilitates, the same snack facilitates a highly localized absorption of semaglutide. Remember I told you about permeability, it's not able to go in. That is also solved. Slowly now it is able to go in. And all these have caveats because unless you take it in the proper way, it will not. Now the bioavailability is still low. So that is something which we still haven't got over. Maybe with further development, maybe the bioavailability will further go up. And there is some variability in the absorption also, which is again not fully solved, but this is as far as where science has got. Now, that is why it becomes extremely important, and every one of you should know this very well, because if you don't spend time, when I write ribelsis for somebody, I spend a clear 5 minutes explaining it to them and then ask them to repeat it. Because sometimes they won't be hearing or they won't be listening. And then, what did he say, before food or after food? He'll get a doubt after he goes home, okay? So number one, you say it slowly, repeat it, ask the patient to repeat it, and then write it down in your prescription. If you do all this, I think they will follow, okay? Because you tell them, you're taking a costly tablet. If you don't take it properly, it's a waste. Don't even take it. So it's very, very, very important. So take it first thing when you wake up in the morning. We know with with L-Troxin and things, we're already used to doing that. But this is very, very important. In fact, one of the things people ask me is, should I take L-Troxin first or this first? I'll take this first. Then all L-Troxin can wait. First take this, okay? So take your semaglutide straight away. Half glass of water, very, very, very important. After a lot of studies, they've come to this. You shouldn't take too much water. You cannot take it without the water. And all this relates to the permeability issue that we talked about. About 100 to 120 ml of water. One glass is about 250. You take half of it, you're good. And then wait for 30 minutes before you drink either water or tea or coffee, because all of us are in a hurry to get our morning tea. Okay, so some people ask me, can I go for a walk? I said, if that's what you want to do, you do. If nothing else you want to do, go for your walk, come back and then have your tea. But please don't drink your tea before you go for your walk. So wait for 30 minutes and do that. So you normally start with 1 month of this 3 milligram. And I was just discussing earlier with Vijaya and others. Some people have said that even 2 weeks is enough. I've tried this as liraglutide, trying to cut it down, and some people vomit. So you have to be careful. But if the patient is able to tolerate it well, there is sense in cutting it down a little bit. I would say even 2 weeks we can try, because what happens is, my practical experience, at the end of 1 month, they think weight would have gone down 10 kilos and because the amount of money they're paying, and then also A1C would have dropped, which can't happen in 1 month's time, obviously. But with 3 milligrams, some people don't respond that well. With 7, they all respond. Some people respond even with 3. So it's better to tell them there's only a starter, so just take only half of the dose for 2 weeks. Don't expect any results, but this is just to get your body used to it. Make that also very clear to your patient, because compliance is very important. There's no point in them taking it 1 month, 2 months, then dropping out. Might as well not start it. This is meant for long-term use. So tell them to start with 3 milligram. At the end of a month or earlier, escalate the dose to 7. And then take it from there. If they are able to tolerate it, do very well. If the effect is very good, they themselves will agree to go to 14 milligram, because they are seeing the benefits of it. So to summarize, ladies and gentlemen, peptides are always very challenging, and to produce an oral form is nothing but short of a miracle, a pharmacological miracle, or pharmacological engineering, which they have done. And then now these peptide analogs are designed to offer improved stability and a prolonged half-life. Absorption of oral semaglutide takes place in the stomach and requires co-formulation with SNAC. And then the mechanism of absorption is shown to be compound-specific, transcellular, and without any evidence of effect on the tight junctions. And today we are celebrating the development of a peptide in a pill, which is definitely a big breakthrough. But as I always tell my team at my center, I always keep telling them that the best is yet to come. Thank you.
Thank you, sir. Thank you very much for the wonderful lecture, where we developed from lab, and today we are here launching Ribelsis. And so just to answer your question, you already know we are the protein people. And of course, we are the fatty acid people also, because we have understood that albumin has got 7 binding sites. Each albumin molecule has got 7 binding sites for fatty acids. Yes, sir. Yes, sir. Acylation of fatty acids. Yes, sir. Yeah. Yes, sir. So thank you very much for the wonderful lecture. So moving on to the next, another interesting session. Pioneering new standards in efficacy and safety, the clinical trial voyage of oral semaglutide. For this, we have Dr. Arpandev Bhattacharya with us, and who is a consultant diabetologist, endocrinologist at Shiva Jyoti Clinic, and also a visiting professor in diabetes and endocrinology, JJM Medical College, Davangere, and also clinical investigator of more than 30 clinical studies, and with authorship in more than 140 publications in both international and national journals. and also authorship of patient information booklets in diabetes, thyroid disorders, and hormone disorders, and received P.N. Shaw Annual Oration of Endocrine Society of India at Bhubaneswar in 2018. And sir also has initiated a program in fellowship in diabetes and endocrinology at Manipal Hospital, Bangalore. With this, I over to you, sir.
Thank you very much. Thanks, Dr. Vijaya. Thanks, Shashank team, Indian Academy of Diabetes and Pneumonics, for bringing me here. Fed up for last 2 years speaking in front of the computer. It's so nice to see people. Okay, so quickly we'll go through. So my part of the job is a nicely built up story. So my part of the job is to talk about the pioneer study. We have heard this, all the development, the molecule, how it works. So what's the evidence? That's very important. So this is what it is. For the clinical development program, we have now experienced more than 5,700 before launching, which will include the pharmacological study, phase 1 trial, and phase 2 trial, which I'm going to tell a bit quickly. So any program gets a fancy name. For example, with liraglutide, it was a leader. Then with semaglutide, it's sustain. We don't talk much about sustain because once in a week semaglutide is not available with us. What is available is oral semaglutide. So the development program goes like that. Initially, we start with a new diagnosed diabetes, placebo control trial. Then we combine with a different other molecule, like here with the SGLT inhibitor, background of metformin, gliptin, background of metformin, sulfonylurea, then GLP-1 receptor injectable one, flexible dose, then with insulin, and then some special population like the renal people and cardiovascular people. So Pioneer 8 was done, and Pioneer 6, part of this, we participated in the Pioneer 8 trial. And Japan, I believe, has some different need is there, legislative need is there, so they have some different others way to do a bit of more data collection. As a rule, any of these clinical trial will have a primary endpoint and confirmatory secondary endpoint. And obviously, we are talking about the diabetes molecule. Our primary endpoint is to glucocentric approach. Whatever we tell, we are using this for people with the diabetes, we need to reduce the blood sugar. I agree with the extra glycemic benefit. So our primary endpoint is HbA1c reduction, and very importantly, this is very important, that our target is less than 7%. So we need to see how many people who participate in the clinical trial, HbA1c is coming less than 7. That's called proportion of the patient achieving HbA1c target. Secondary endpoint, body weight, hypoglycemia, and so on. And Pioneer 6 was the cardiovascular trial, so we wanted to see the cardiovascular event. MACE stands for Major Adverse Cardiovascular Event. And here we tell 3-point MACE, which is a cardiac death, non-fatal MI, and non-fatal stroke. Now we have established now 5-point MACE. Two things we add. One is a hospitalization for the heart failure and hospitalization for unstable angina. And we want to see the benefit of this. People recruited more than 18 years, type 2 diabetes, at least 3 months, HbA1c, in some of them 7 to 9.5, some of them 7 to 10.5. And background treatment should be stable, as any clinical development program with the diabetes molecule. We've excluded proliferative retinopathy and maculopathy. This is mainly because a very small proportion of the people with injectable semaglutide had some problem with the retinopathy worsening. And that's not because of semaglutide, that's because very rapid reduction of the blood sugar. But in that case, we have excluded them. We have excluded medullary carcinoma, thyroid, and MAN2, not probably a very great prevalence in our country. Pancreas, smell, we don't want to take. Any surgical procedure in the stomach, we have excluded in this all Pioneer program. That's because we need lower part of the stomach for it to get absorbed. Dr. Mohan certainly told just now. Anybody had a major atherosclerotic cardiovascular event within last 6 months, and also a life-threatening malignant disorder have been excluded from the trial. Now let's see the result. Our first result we wanted to see about HbA1c reduction. We have 3 milligrams, 7 milligram, 14 milligram. I want you to concentrate on the deep blue bar diagram. That is a 14 milligram. That's what the dose we want to give unless there is a problem with the tolerance and so on. So if you see that, from left to right, monotherapy with EMPA, with CETA, with the LIRA, with the renal flex, and uniformly there is a good HbA1c reduction of between 1.1 to 1.5%. Now, if you see the other way to look into that, that how many people reaches the target, that's very, very important. And it is probably the only molecule, Dr. Mohan kept on telling this again and again, probably the only molecule which showed some of these, and 80% of the people are reaching the target, which is less than 7%. You see the blue one from something like 64 to 80% overall. Okay. We have spoken about body weight reduction. It is very, very important for our treatment of type 2 diabetes. And again, the deep blue diagram, if you follow, the body weight reduction probably in the range of 4 to 5 kg in this clinical development. So up to 5 kg of weight loss, we can expect about a time of around 6 months if we can use 14 milligram of semaglutide. And this is a very important because when we talk about the metabolic weight loss, that we talk around 4 to 5% of the weight loss. When you are talking about cosmetic weight loss, bariatric surgery, that is a different issue. This is a metabolic weight loss. So if you see here, around 40 to 50% of the people are losing weight 5% or more. If you take two parameters together, people reducing HbA1c by 1% and body weight by 5%, you see in comparison to the different molecule, for example, in comparison to placebo, 10 times more chance that oral sema will do this compared to CETA, to EMPA, to LIRA, to placebo. Obviously, there is more than 8 to 10 times more chance that you will be losing HbA1c 1% and losing weight by 5%. Safety summary, we have more than 5,000 patients have been exposed. Only thing which I need to be worried about, I think we have not spoken this till now in the panel discussion, I'm sure the question will come about the gastric intolerance. Some of the people we expect as a part of this group of medicine having some gastric, it is all our style, how we need to educate the patient, counsel the patient to avoid this. Very low rate of hypoglycemia, we don't like that, and no new unexpected safety signal from the oral signal trial. So cardiovascular outcome trial, we have spoken about this. This we are talking about Pioneer 6, as you see. So initially it can be an inferior, it can be non-inferior, which is neutral, it can be superior. So in this trial, we have a neutral or non-inferior. So although you see the hazard ratio of 0.79, there is a 21% reduction risk of the 3-point mesh, but it did not reach the statistical significance for superiority. So at this point, standing here, we will tell it is non-inferior, it is neutral, it is not doing anything harm to the heart, but we are waiting for a better cardiovascular outcome trial, which I believe will be available in 2024, which is called SOUL trial. And as you see this cardiovascular primary endpoint, whether it is a non-fatal MI, non-fatal stroke, or cardiovascular death, there are 21% reduction is there. Numbers are a bit small. For example, only cardiovascular death, there are 51% reduction in relative risk, but it did not reach the statistical significance because the numbers are not more. So we need a more trial. Sriram has shown this slide. So in nutshell, 1 is a very important. Anything left of 1, it will favor semaglutide. Anything right of 1, it will favor placebo. So SUSTAIN 6 with injectable semaglutide, you see the right arm of the confidence interval, it did not touch 1, which essentially means it is superior. But if you see the Pioneer 6, in oral semaglutide, right side of the confidence interval, it crossed 1. That means it is a non-inferior, but it is not superior yet. But if you do a pool analysis, which is not the best way to do the clinical research of SUSTAIN 6 and Pioneer 6, we are talking together about injectable sema and oral sema, it actually showed superiority. So we are very hopeful that our SOUL study will prove the superiority and will be in a better position to use in our clinical practice. So in summary, we are reducing HbA1c better than EMPA, CETA, or injectable LIRA. We are reducing more weight in comparison to CETA, LIRA, and EMPA. Cardiovascular safety at this point, non-inferior. Overall safety, no unwanted safety point. Only the gastric side effect, we need to be a bit careful and counsel properly. Thank you very much.
Thank you very much, sir, for taking us through the wonderful insights of the pioneer clinical trials and to have better patient outcomes. Thank you very much. And with this, we move on to the plenary session 3, a value story of optimal glycemic control. To set the context, we have none other than Dr. Rajesh Rajput, who is going to talk us about waking up to the newer possibilities with GLP-1 receptor analogs. As you all know, sir is the senior professor and head of Department of Endocrinology at PGMS Rohtak, and sir has more than 170 publications in various national as well as international journals, and author of many books like Endocrine Disorders in Pregnancy, Women Health in Diabetes, and also contributed to various chapters in textbooks like Diabetes and Endocrinology.
Thank you, Dr. Vijaya, and we will save some time.
Okay, sir, sure. Thank you.
So thank you very much. Good afternoon, everyone. Well, you are listening about oral GLP-1 semaglutide symposium. Already learned about the science behind how this has been produced. Last lecture you have learned about pioneer trial, which is very important. And now I am going to take you through some of the newer possibilities of GLP-1, largely discussing about how to calculate, how to talk about cost, because when it comes to choosing a drug or otherwise also in India, we often talk about cost. So this is a very big issue. But when it comes to diabetes, remember in our country, there are more than 77 million people with diabetes. And over next few years, the number is going to be more than 134 million. What is most important is that more than 50% of the people does not know that they are having diabetes. And although we talk of so many diseases which are killing acutely, infectious disease, COVID deaths and so much, but if you see the numbers, with diabetes, every day more than 2,700 people die because of diabetes. So it's a serious disease. We have to take it seriously right from day one. There is nothing like mild diabetes. Diabetes की अभी शुरुआत हुई है, so we can wait for some time. This concept has to go first out of our own mind, out of physician mind. Unfortunately, if patient do so, it's fine. But in our large physician community, this concept is so deeply ingrained that diabetes की अभी शुरुआत हुई है. But this is not the truth. If you see the challenges and why I am telling you, I will tell you in the next slide. What are the key challenges with so much of high prevalence? The challenges is, it is not only disease burden, the associated comorbidities. If you see, diabetes happens in our population at least a decade earlier, which means we are going to live a pretty long part of our life with uncontrolled diabetes, which is going to result in development of micro and macrovascular complications. And then there are barriers. Because of only 10 minutes allocated to me, I will not discuss in detail. There are patient-related barriers and there are physician-related barriers. But to me, physician-related barrier is a big problem actually in bringing diabetes under control rather than patient-related barrier. We cannot blame our patient. They are ignorant. They are not doctors. But what about doctors who have been trained in medicine, who does not practice the medicine the way it should be practiced? So that barrier needs to be removed, and there lies the importance of these educational programs. And then last barrier is cost of the treatment. We often talk about cost, how costly it is. But then when we are talking of the cost, we have to remember that why I am saying that there is nothing like mild diabetes, diabetes की अभी शुरुआत हुई है. If you are not aggressive even in the initial first year of diagnosis. Remember, initial first year of the diagnosis, see the numbers of increased prevalence of micro and macrovascular complications. Both are increased if we are not aggressive initially. So friends, when you have diagnosed diabetes, you have to be aggressive right from day one. Bring your patient into control as early as possible. Otherwise, you will generate a bad legacy which is remembered by body. So even when you become aggressive later on, patient keeps on developing these complications irrespective of the fact that what are costly form of therapy you are using. Another important message, again this is deeply ingrained in our mind, that costly medications has to be used later in the disease course. At least in diabetes, this is not the truth. It is the medication, it is not the cost of the medication. Proper medication, irrespective of the cost, has to be used earlier in the natural history of diabetes so that patient does not develop complications. When it comes to the cost, obviously we often talk about cost of a pill, cost of an injection, which only actually, at least in diabetes, amounts to 50% of the cost. What about cost of repeated testing? What about cost of visiting physicians frequently? What about cost of losing daily wages? Because if patient has to visit a doctor, he is not going to earn on that day, or he has to take a casual leave or whatever type of leave. That also cost. What about cost of quality and quantity of life with which diabetes is going to come down? You know, an average type 2 diabetes, if not controlled, lives less than 10 years as compared to a non-diabetic. And if we take it into a quality of life, it will translate into more than 15 to 20 years. But in our financial calculations, we does not take into account all these indirect costs, which actually amounts to more than 50% of the cost of management of diabetes. And when patient develop comorbidities, just focus on the last number, that is patient develop CKD, patient develop myocardial infarction, patient develop stroke, the cost increases 48%. So we have to avoid all these issues. Pill burden we can skip. All of us have gone through an era when I was a student, only one drug, one insulin was available. Nowadays, treatment of diabetes has become complex, a subject in itself. More than 10 different class of drugs are available. All have some limitation. GLP-1RA is a new class of agent. I will not discuss into the detail. Already lots of discussions has been done. But then it addresses many unmet need in management of diabetes. It does not cause hypoglycemia on its own because it stimulates glucose in an insulin-dependent fashion. It has a weight losing benefit which is not seen. It is CV safe, it is renal safe. And often comparison between SGLT2 inhibitor and GLP-1RA come up. And this is one of my favorite slides which I have put up, asking Novo to put up this slide, because we are often in a mindset to compare apples with oranges, which is no point. Apples are apple, oranges are oranges. But for SGLT2 and GLP-1RA, in this one slide, I have tried to summarize the basic comparison between two class of agents, and these are side effects which are observed with SGLT2 inhibitor, like volume depletion, genitourinary infection, some issue with fractures, issue of amputation, which has been seen with canagliflozin. In contrast, if you see with GLP-1RA, as you have listened in previous lecture, the risk of nausea, vomiting, that is GI side effect, which is a limiting side effect, largely they are safe and neutral. And with GLP-1RA now going to be an oral pill, except cost, now we can have a head-on comparison of benefits and harms. Not only that, all of us know about omnious octet, that is 8 different defects in diabetes. How many out of these 8 different defects GLP-1RA addresses? At least 6. The remaining 2 are defect at the level of kidney and defect at the level of muscle, where glucose is utilized. But if your insulin resistance is improved, which is done with GLP-1RA, even glucose uptake by the muscle is also improved. So what only remains? It is only kidney, where SGLT2 is. So there is a C difference between two class of molecules. There is no point in comparison. Their addition is a beneficial effect rather than comparing them. If patient can afford, actually we can utilize combining GLP-1RA with SGLT2 and a metformin, and that is probably wonderful most thing for most of our diabetes to do. Now coming to snack technology, I am not going to repeat it. Already it has been discussed so much of time that how an injectable GLP-1RA SEMA has been combined with snack, where it improves absorption, improves permeability. But remember, despite these technological advances, only 1% of the drug is going to be absorbed. Only 1%. And that is why patient education that how to take this drug is going to be most important. So friends, with oral GLP-1RA, based on number of benefits, we have a drug where it is compared with sitagliptin, EMPA, LIRA, which has been discussed in last lecture, found to be wonderful as far as reduction in HbA1c is concerned, as far as reduction in weight loss is concerned. Now this is roadmap for beneficial effects and number of other benefits with GLP-1RA. Will not again goes in detail because time permission is not allowing me, but as you see, there are in last decade at least, there are at least 10 different mechanistic studies on GLP-1RA, that why it is providing benefits beyond glucose reduction. And those mechanistic studies have produced that with the use of GLP-1RA, there is improvement in endothelial function, there is vasodilatation because there is production of nitric oxide into vascular endothelium, it provides plaque stability, improves blood flow, it provides natriuresis at the level of kidney where it provides renal protection. There is reduction in inflammation, which is very important when we are talking of heart failure with preserved ejection fraction. It prevents smooth muscle cell proliferation and it prevents platelet aggregation. So large number of benefits, and that's why we have observed some of the benefits with LEADER trial, with SUSTAIN 6 trial, with REWIND trial, where CV outcome trials have shown benefit. But when we are talking of CV outcome trials, we always only talks about myocardial infarction, because myocardial infarction has been glamorized so much in our community that we often forget to talk about another important component of 3-point MACE, which is non-fatal stroke. And it is worse to live with a non-fatal stroke as compared to a non-fatal myocardial infarction. And if we see our anti-diabetic drugs, hardly any anti-diabetic drug is present which actually reduces the risk of non-fatal stroke. If we see GLP-1RA as a class, directly through acting at the area of nucleus tractus solitarius, as well as its effect on vagus nerve, it has been observed that there is reduction in non-fatal stroke with the use of GLP-1RA. The same has been observed in SUSTAIN 6, same has been observed in PIONEER 6. So we have a molecule where it has been observed that even non-fatal stroke is reduced with the use of GLP-1RA. If we see the time to event analysis regarding stroke and its subtypes, if you see all type of strokes, the risk reduction is around 18% with the use of GLP-1RA. If you classify into different subtypes like ischemic, hemorrhagic, and undetermined, probably more benefit is observed in ischemic stroke. So friends, pooled semaglutide data clearly suggests a significant 32% risk reduction in stroke as compared to placebo. And there is no heterogeneity in data. If you talk of injectable semaglutide, if you talk of oral semaglutide, if you talk of liraglutide, benefit on stroke is homogeneous. In contrast, in various CV outcome data, there is heterogeneity with regard to reduction in non-fatal stroke. Another important point, which Dr. Arpan has touched up, in extended 5-point MACE analysis, in oral semaglutide, it has been shown there is a non-significant reduction in heart failure with reduced ejection fraction. And in one of the recent meta-analysis, where all GLP-1 trials are included, it has been observed that with use of GLP-1RA, there is a 9% significant reduction in hospitalization for heart failure with reduced ejection fraction. So there are lots of benefit which we are discussing since morning. I will like to stop with last 1 or 2 slides, that when you are going to start a GLP-1RA, now oral semaglutide, rebalances in clinical practice, start slow, titrate the drug, do patient education, because only 1% of the drug is going to be absorbed, and if you want to have a total effects, please do this educational program. Lastly, discuss expectations of the patient. It's a common, again, Indian mindset. If we take a costly drug, we expect so much of benefits to happen, especially when you are talking about weight loss. There is a difference, which Dr. Arpan has told you, difference between a weight loss therapy and a metabolic weight loss. Discuss the expectations, discuss the side effects, which are not serious, which are mild to moderate, which are class effect of GLP-1RA, which are going to subside, and discuss some other issues, behavioral changes, which are going to. To summarize, journey of GLP-1RA, which you have learned from morning, started from injectable one, and now we are having oral semaglutide. It holds promise, as we have seen from clinical pioneer program, where it is effective in reduction of HbA1c as well as body weight. It has huge number of benefits going beyond glucose lowering, and these pleiotropic benefits probably make oral semaglutide a drug of choice in spectrum of type 2 diabetes patient. Please do not wait to start this costly medication till late in the natural history of type 2 diabetes. Thank you very much.
Hello. So after these three wonderful talks, let us go to the expert panel talk show. And I would like to call on stage Dr. Sunil M. Jain, Dr. Om Lakhani, Dr. Amay Joshi, and Dr. Jugal Gada. We all know Dr. Sunil M. Jain. Dr. Sunil M. Jain is one of the foremost endocrinologists from Central India. He's from Indore. He has done a lot of cutting-edge work. We need one more chair. Or ek chair lege. He has done a lot of cutting-edge work in the field of endocrinology and diabetes. He runs the Total Clinic in Indore. Then, of course, we have Dr. Om Lakhani. He is from Ahmedabad. He's at the Zydus Hospital. He's one of the foremost endocrinologists in the country. Very active in our endocrine society, very active on Twitter, social media. He's one of the faces of the endocrine society. Then we have Dr. Amay Joshi. He is also very active with our endocrine society of India. He's very much from Mumbai at the Bhakti Vedanta Hospital, formerly a faculty at B.I. Nair Hospital. And Dr. Jugal Gada is one of the brightest endocrinologists we have in the city of Mumbai. So we are really going to now do a panel and ask a couple of questions to our expert panelists here. And if anybody in the audience has some compelling questions, we might take a question or two. So my first question to you is to Dr. Sunil M. Jain. Sunil, you beautifully explained in your talk, what do you feel is the rationale? When would you consider semaglutide for oral GLP-1? You know, when you have a choice of injectable and oral, what would be your compelling rationale to choose or consider semaglutide?
So, Shashank, as it has been discussed earlier also, we understand that between injectable and oral, obviously a patient preference will be a oral therapy. Now, if we look at the oral formulation, we have already discussed how this peptide came into a pill by addition of snack and the amino acid alteration, which is not allowing the degradation in the stomach. Now, when we look at the GLP-1 as a pharmacotherapeutic agent, we know that it is working in the glucose-dependent manner. And that's how we are not concerned about hypoglycemia. So we just want a constant level. And when we give a oral therapy, we are giving in milligrams, and already we have talked that only 1% is getting absorbed. Injectable therapy of semaglutide, which was once a week, which was also a very good option, but which was not launched in India by Novo Nordisk. And I believe that the perception behind that is the oral molecule is going to succeed better in our country rather than injectable. And there, if we look at the injectable semaglutide, they have 0.25 milligram to initiate, then to go to 0.5 milligram, and then to go to up to 1 milligram if required. And now recently, FDA has approved up to 2 milligram also in the injectable. And when I look at its correlation in milligrams, what I can see, when our patient is taking, say, to give a numerical analogy in an easy way, let us talk about the 14 milligram pill. Now, if the patient is taking 14 milligram pill once a day, it will be around 100 milligram in a week. 1% getting absorbed. that means 1 milligram will reach into the system. And we know the half-life of the oral semaglutide is around 165 hours. So if we can make 1 milligram reach into the system, that will be equivalent to the injectable 1 milligram, which was so far near maximum dose for the injection Ozempic. So I think oral semaglutide is a good proposition for us. Patient acceptance has to be quite high in this molecule. And if I look and compare with the injectable, I feel that we are going to get the same quantum of semaglutide in the patient circulation, which will be equivalent to the injectable. And that's how this is a good option.
Thank you, Sunil. Om, a lot of people have to learn about this snack, SNAC. And it's like a oral absorption formulation. Can you tell us a little more about this snack? And do you think, even Dr. Mohan made a passing reference to that. Do you think that this snack backbone will lead to eventually oral peptide delivery? Do you think that Novo Nordisk has paved a way in that direction? Can you give us some insights into that?
Thank you very much for the question, sir. And thank you for having me for this. Thank you to Novo Nordisk. So good morning, everyone. If you believe in omens, there's a bottle in front of me which says clear, change is here. Now, I don't know whether it's a coincidence or maybe it's by design, but I think, I very strongly believe that today we are all perhaps early adopters, but I think very soon we'll see oral semaglutide, just like we saw with DPP-4 inhibitors some time back or SGLT2 inhibitors. We'll see the use of oral semaglutide become bigger, and the overall use of this molecule become bigger, and our experience with that also becoming bigger. Talking about snack, I think giving a peptide orally has always been a challenge. And there were many options, I'm sure, in front of Novo Nordisk for choosing something which is known as a permeation enhancer, right? So this is an intestine or a gastric permeation enhancer. So this agent, basically snack, what it does is it helps the absorption of the peptide through the GI tract. So as we already discussed, taking something through the GI tract is a very complicated process. There are a lot of barriers through the system. There are mucus, there are the various pH changes that happens throughout the GI tract. So many challenges which stop a peptide from being absorbed orally. So by adding this snack in the right dose, in this case 300 milligram, they are combining with this molecule. They are producing two things. One, they are changing the pH to a neutral pH. So they are changing the gastric pH to a neutral pH, helping the drug from being absorbed. Secondly, what is very interesting, this was also said in one of the earlier presentations. Remember, the absorption is transcellular. So it is absorbed through the cell, and it is not absorbed through the tight junctions. Now, this is very important because if you open the tight junction, that's a potential problem, because once the tight junctions open, there could be potentially, you are breaking the system's barrier, and you are potentially making it vulnerable to other GI infections, which is not happening here. You are just doing a transcellular absorption. So amongst the various options, I'm sure, which Novo had, I think this was a good option because it's a safer option on a long-term basis. Secondly, the question is whether this will open gates for further oral peptides which can be delivered through this same mechanism. I think absolutely the answer is yes. Insulin may be far away, but there are many other oral peptides which are potentially there. For example, a few years back, I attended a conference where there was a discussion on an oral octreotide, right? Now, those patients, those doctors who treat acromegaly or other, neuroendocrine diseases, you know that, again, just like we have issues with injectable here, they need to take an injectable octreotide, long-acting, once a month, which is painful injection. So they have now working towards development of an oral octreotide, right, which is now undergoing trials and perhaps will be soon available. It uses the similar mechanism as this oral semaglutide. You also have potential for now, a lot of you would have heard about teriparatide, right, or PTH, which is a very important molecule, again, for osteoporosis, which is again an injectable, again a daily injectable. Again, patients have problems with taking a daily injection. So oral PTH is another molecule which is now potentially being developed. Another development throughout in the same space of osteoporosis is an oral calcitonin, which could also be potentially delivered. So these are already in the pipeline. They are undergoing clinical trials. So these are mechanisms by which you can deliver other peptides through the system And I think if you see from the Novos table itself, perhaps in the future, maybe a decade from now, we might see an oral growth hormone as well. Remember, again, growth hormone used in children, again an injectable, again painful, and now we are dealing with children, which is even more complicated, as you know. So that becomes a challenge. So perhaps you'll see an oral sema. And I think insulin is a little far away, because amongst all these peptides, it is the largest one. It is close to 6,000 daltons. And the larger it is actually more difficult to deliver the peptide. The more other challenge is that you need to have precision with insulin. That's a problem, because remember, if there is a variation, you might have the patient in hypoglycemia one day and hyperglycemia the other. So you don't want that. So I think it's still a little far away, but I think we have opened the gates there. And I think with increasing knowledge about this mechanism, I think we are now opening a new era of potentially delivering more peptides to the GI tract. And on a pop quiz, remember this, the semaglutide is currently absorbed through the stomach and not the intestine. So I think that's one thing I learned today, which is, I think, something which I'm going to carry home. Thank you.
Thank you so much. So it's a stomach peptide, as we stomach our food after some time. So that's a good way to say semaglutide is a stomach peptide. Amay, that leads me to the next question. Can semaglutide be used in people who have upper GI disorders or people who have cut their stomach like bariatric surgery?
Thank you, sir, for having me here, and thank you, Team IID and Team Novo. I think it's a very straight and clear question which is we all are going to face. Because by the time you start telling about a new medicine, the second thing that you tell about is that you may have to accustom yourself. Dr. Rajput sir was telling, Dr. Arpan Dev sir was telling. And the patient, you will tell that this may cause gastric upset, And the patient will definitely say, but doctor, I'm already having one. So the question is the patient eligible for that? Will it work? And will it cause more trouble to the patient? And the answer comes from the Pioneer trial itself. First part of it is, will it get absorbed? And then the pharmacokinetics tell us that those who have gastritis or GI disturbances and those who did not have were sub-analyzed, and it was realized that oral semaglutide is well absorbed even in those who have gastritis or GI disturbances. Now, the other part is, will they be more vulnerable to side effects and discontinuation? Now, here comes the relief, because the Pioneer study has sub-analyzed those populations who had gastric disturbances and who did not have and were initiated on oral semaglutide. And those with gastric disturbances did equally good or bad as compared to those who did not. So probably it's a reassuring thing and something that you can really use in your counseling, that okay, we are covering up with some antacid. We are actually giving you some reassurance that past experience of the world doesn't tell us that you are more vulnerable to discontinuation. Now comes the bariatric surgery, or the crux of the matter, because that is the population who will want to use it. There is an indication for liraglutide for post-bariatric surgery weight gain. But here comes the limitation. Remember, it's absorbed to the stomach. And in bariatric surgery procedures, most commonly sleeve gastrectomy is quite frequently done. And these were the population groups. Those who have undergone a partial gastrectomy, sleeve gastrectomy, major surgical procedure on the stomach was the population that was excluded from the Pioneer program. We saw the exclusion criteria, and this was the population that was excluded. So one, if you are using it, there is no data to support the use. Nobody has used it in a clinically trial supervised program. And so the use is clearly off-label in this population, and probably what happens is not well studied. So for a bariatric surgery, patients who had already had bariatric surgery, probably it's not something you better go to an injectable. Thank you, sir.
Thank you, Amay. Jugal, what is the clinical relevance of this dosing recommendations? Can you educate the audience on these dosing recommendations with oral semaglutide? Because if somebody has to use it, how does one do the dosing recommendations with oral semaglutide? Dr. Jugal Gada.
Thank you so much, sir, for the question, and thank you, Novo, for having us here. So the dosing, as they've already put out, it's 3 mg, 7 mg, and 14 mg. So you start with 3 mg. As sir rightly pointed out, only 1% is getting absorbed. So you're supposed to use that 3 mg for a month. So the patient is actually getting used to the drug. You're achieving your steady state level in that 1 month. The patient is getting accustomed to the side effects, which are the GI intolerance, which is usually minor and which over a period of time eases out. Once the patient has tolerated that 1 month of 3 mg, then you shift him to 7 mg. That is the time where you'll get the maximum glycemic benefit and a good amount of weight benefit. And if your patient tolerates it further, you jump up after a month from 7 mg to 14 mg. So this jumping up of the dose has to be done gradually over 1 month periods of time. Currently, the company doesn't have enough evidence to do it faster. That is, every 14 or 20 days or something. So you have to be slow. Let the patient get accustomed to it, which is very important.
Thank you. We have a few questions. We have a couple of minutes. Yeah, go ahead.
Say example PPIs. So how do we dose PPI along with the semaglutide?
So any drug interactions like PPI, anyone can take that question. Yeah.
So the studies, or there are little bit of evidence that says that if you are on a PPI, in fact, the enhancement of absorption is even better. Because if you remember in one of the slides before, the snack protein, basically, it neutralizes the pH of the acidity in the stomach, and then the absorption happens. So PPIs will in fact enhance the absorption. But always remember, as a thumb rule, महंगा दवाई सबसे पहले. That is what we were just joking about. So if you're gonna use, first is the semaglutide, and probably after 30 or 40 minutes, then you use your PPIs.
The second question correlated to this is, how do we use L-troxin?
So the same thing. First, you use the oral semaglutide, and after half an hour, then you use your thyroid tablets.
So that means a person will be empty stomach for almost 1.5 hours?
For at least 1 hour for sure, yeah.
Dr. Modi from Danu. Yeah, I'll come to you. Dr. Mayur Mehta after that.
But after reaching the therapeutic target, suppose it is glycemic control or a weight loss, do you de-escalate the dose as a maintenance dose?
Yes, sir. Sir, so far we do not have too much experience in de-escalation. We don't have data as well. What I believe is looking at the overall cost, structure which Novo has. I think from a cost point of view also, it perhaps makes no sense to de-escalate, because you're almost paying the same for a 3 and 7 and 14 milligram. And what we observed so far from our clinical practice is that patients who are comfortable at a particular dose. So it takes a little while for patient to be comfortable from the GI side effects and so on. Once they're comfortable, patients adjust to that dose very well. We also learned this from liraglutide also. So if you know liraglutide, once you go from 0.6 to 1.2, even though there is a doubling of the cost there, once they're comfortable, it's better to keep him there. But from that small experience I have of some patients who have perhaps for some reason being de-escalated, what we observed is that after a few days, remember, this is a long half-life drug. So it takes, any dose changes will take few more days to reflect its clinical effect, right? Both in terms of glycemic control as well as the side effect profile. So what we have seen is that for a few patients where there was some reason to de-escalate, the patient actually starts feeling more hungry, and the glycemic effect starts a little wearing off a bit. So in my humble opinion, without data, I would say I would not generally de-escalate. I would perhaps keep the patient on whatever dose they're taking. If they're comfortable with it, there are no GI side effects, and after a few weeks, I'm sure they won't have. If they're comfortable with it, they're tolerating it, and there's no compelling
Thanks,
reason.
Om. Yeah. So Mayur, quick question, and then Dr. Das is here, so we'll start. We'll continue question and answers a little later.
You mean to know the so the effect of GLP-1 based therapy on insulin secretion. That is what is the question. if you differentiate between a DPP-4 inhibitor and a GLP-1 analog. So here, the information is, if you look at the effect on alpha and beta cells, there you require little lower GLP-1 in the system as compared to effect on the satiety, brain effect, weight loss, and other things which we are talking there. You need a very high GLP-1, and that can be achieved only with GLP-1 receptor agonist. Now, in terms of just insulin secretion, if there are enough L cells and DPP-4 inhibition is able to create an endogenous GLP-1 level which can reach around 2.5 to 3 times with DPP-4 inhibitors, then we can have a more or less similar insulin secretagogue effect with GLP-1. But the GLP-1 level are going to create 10, 20, 30 times GLP-1 level. And there we are going to see the beyond glucose lowering effects. That's where is the big difference between GLP-1 and DPP-4 inhibitors. Yeah, these all kind of studies have already been done.
So I'll ask Vijaya to coordinate with you, doctor. We will continue the question and answers. We are going to have one more expert panel. We have a lot of people having a lot of questions. I can see Dr. Das is very much here. So thank you so much, Dr. Jugal Gada, Dr. Amay Joshi, Dr. Om Lakhani, and Dr. Sunil M. Jain. Put your hands together for them. And let us now invite Professor Ashok Kumar Das. He's an expert at all these talk shows. He's really a professor of medicine, dean, director, former director of Health Services, Government of India, former director and dean of JIPMER Pondicherry, endocrinologist par excellence, and an outstanding speaker, orator, and a clinician. So he's going to conduct the next expert panel show. And Dr. Das, a lot of people had questions. So, we will take the initial questions quick and fast, and then we'll again have a nice round of introduction, and then I'll join in for the closing in. Professor Ashok Kumar Das. Put your hands together for Professor Das.
Thank you. Shashank, thank you very much, and thanks to Novo, thanks to Indian Academy of Diabetes for this wonderful opportunity given. Now, the time is short, but the art is very long, so we'll be directly going to the discussion. May I invite the panelists for this talk show, Mangesh, Dr. Mangesh Tewaskar, the proverbial physician, diabetologist from the city of Mumbai, the editor. Next month, he takes over as the full editor of JAPI. Gold medals, one cannot count, and very absolutely gifted with writing and speaking. Mangesh, welcome. I'll be very brief in my introduction. Next is Dr. Priya Balani. Priya is the endocrinologist at the Bombay Hospital. She has her own center at Kolaba, and she has excelled many international trials and papers in the US and India, and has contributed immensely in the field of endocrinology. I'm very, very brief in the introduction. Next, Dr. Girish Parmar. Girish has a very, very, very important career, as all the four have. He practiced in the Villapure in Mumbai. He has completed MBBS from the MGM. Following that, he had DNB General Medicine, and following that, he had endocrinology super specialty degree, and he is practicing in Mumbai, the Villapure Hospital, and also in the Nanavati Super Specialty Hospital. Dr. Hemant Patale, he is the proverbial endocrinologist for the city of Aurangabad. He has got the Samrat Institute of Endocrinology, Diabetes, Metabolism, and very prominent, very senior person. Welcome, Hemantji, to this meet. Dear friends, we have this talk show, and I'll be asking the questions, and the experts will answer. And after that, time permitting, we'll take a few questions. We'll see what we can do, till what time we can continue. The first thing that I'd like to mention, these questions are absolutely practical, and what we should do in our clinical practice. That's why I like these questions. And this has been specially made to aid all of us in our clinical practice. That's the beauty of it. Mangesh, first question to you. In India, we are very clever, and sometimes want to make it hard. We heard about make it hard. Can oral semaglutide tablet, can it be broken? And can it be broken? First, tell me, why can it be broken? Yes or no?
Clear no.
No, clear no.
Clear no.
Explain, I fully agree with you. It's a very, very significant answer which all of us should hand over as a slip to our patients if they're asking this question. Answer is clear no, emphatic no. Tell me why you say so.
Right now, Mohan sir has beautifully alluded in his guidance to us that if you are giving this medication, there are certain things which you need to be really, really careful. And number one is this, that this tablet has to be swallowed as a whole. Second point I realized from his session was that it cannot be broken, because there is something which is brilliant which has happened with this medicine, which is snack technology, which we all were looking at, right? So this snack actually, as everybody, even Om beautifully alluded to it, is the game changer. It creates a small micro environment at the local mucosal level, which I don't know whether it neutralizes, honestly speaking, but surely uplifts the pH. So whether it takes you to the neutral level or not, that is still, under the research, but it surely increases the pH at the local level. So it creates a sort of a micro environment which enhances the cellular reabsorption or the cellular permeability. Now this is extremely important, so that this tablet has to be clearly not to be chewed, not to be crushed, not to be broken. And another thing which I want to bring it to the notice of this august audience is that it has to be swallowed with adequate water, not more as well, because this drug gets absorbed in the stomach. So you don't want to use a glass full of water or probably half a liter of water while taking this tablet, because it will flush it otherwise into the lower GI tract where it is not absorbed. So adequate, just right, probably 3 or 4 ounces or 100 to 120 ml, do not cross more than that. Probably we tend to do that with SGLTs. So these are all few of the tips that, but clear answer, no, surely for breaking up, because you will lose that snack effect.
I think brilliant answer. I'll give an example. This, a definite concentration of snack, as Mangesh beautifully put it, is required to give therapeutically relevant availability of the molecule. If you reduce it or increase it, you know what happens. There's been studies when they have done 5 milligram of this molecule with 150 milligram of snack or 600 milligram of snack. You know what happened? They both reduced the availability of the revelses. So it cannot be done. The other important thing is that they found 2 types of effects, salting out effect and precipitating effect, if they increase or decreasing. So to make a long story short, I like the way Mangesh said it, an emphatic no. It should not be made half, it's taken as full. And with each, whether it is 3, 7 or 14, it is 300, am I correct? Yeah. 300 milligram snack, which provides the absolutely, we call it optimal concentration of snack to make maximum absorption. Brilliant answer. Thank you, Mangesh, for this answer, and congratulations for taking over JAPI from next month. Priya, great to have you here. Priya, I have a very important question for you. And we have been focused many times today with Pioneer 2, which compared the oral semaglutide with empagliflozin. Can you analyze those data and say, how does oral semaglutide takes over or scores over the empagliflozin?
Right. Thank you, Dr. Das. So firstly, I'd like to say, I think Novo, I'd like to applaud them by just bringing about so much more increased awareness about GLP-1 RAs in general. I think the use of this drug across our country, even in spite of so much availability, because of its injectable nature, has not been the choice.
Yeah.
So today, if I have a patient who comes into my clinic, uncontrolled diabetes, overweight, already on metformin, I had a choice in the past, injectable GLP-1 RA or giving them an oral SGLT2 inhibitor. Though we know about the efficacy of the GLP-1 RA being superior, we know about the weight reduction being superior, the injectable nature of the drug always went in favor of the oral drug, and of course that is almost obvious. But now what we have available today is an oral sema versus an oral EMPA, of course, and this was compared head-to-head in Pioneer 2, like Dr. Das mentioned, has been alluded to earlier also. What this showed in terms of the patient considerations, number one, glycemic efficacy at a baseline A1C of 8.1, a reduction of 0.8% with the EMPA, a 1.3 with the oral SEMA. with 14 milligrams, that is.
Yeah.
And of course, this was studied in 822 subjects, all of showing this kind of result. The number of patients, the proportion of patients reaching goal, 7 on 10 with the oral sema, 4 on 10 with the EMPA. So in terms of the efficacy, glycemic efficacy, oral sema won. Next point in terms of the weight reduction, again with the oral sema 14, there was a greater weight reduction. Basically you're talking about 4.7 kilos versus a 3.8 oral sema versus the EMPA. And at the same time, the proportion of patients who got 5% and 10% of weight loss with the oral sema was far greater. Very importantly was that with the EMPA, at the 26-week mark, the weight loss plateaued, but the weight loss continued further up to the 1-year mark, the 52-week mark with the oral sema because of the reduction in craving and the reduction in craving of savory foods. We know that amongst us Indians, we want our chakris and our chewdas, so that is what the oral sema decreased even further. Last thing is the waist circumference decrease also, because we know that loss of your inches also is an independent health marker. The weight circumference loss also was greater with SEMA to the point of around 31%. So in conclusion, I always like to joke and say, SEMA came with its own snack and therefore has left no snacks for us to eat, and hence the weight
Beautiful.
loss there.
Thank you, Priya, for the simile you gave. You know, I think absolutely fabulous. You know, Sasank, we have selected real experts, and my job is very well done. You know, see, beautifully said. You know, we want to reduce our belt size. You know, all of us, the young girls also put on the belts nowadays. You know, it reduces the belt size by 31%. She rightly said, 31%. And the overall BMI, body weight, by 24%. What more you want? And you know, as she said, at the 25 weeks and 26 weeks, it's at 0.8, 0.9, and add 0.5 to it, 1.3 and 1.4. So wherever you give, it is a great, it just scores above empagliflozin, both in weight reduction and of course in glycemic efficacy. This question will be asked again and again. You know, I like the way Sunil, my very dear friend, answered the question that Dr. Sahab has asked. You know, incretin mimetic is incretin mimetic. That is GLP-1 RA. A incretin enhancer cannot be compared to it. He beautifully said that over the studies, insulin is head and shoulder above. That's what the question was asked. You know, so whether it is DPP-4, whether it is SGLT2 inhibitor, I can declare from the rooftop, won't you agree with me, that definitely there is an advantage of this molecule, both in the glycemic efficacy, in the weight reduction, and various other things that we have been listening from morning 10:30 onwards. Beautiful. I think the way it has been planned and done, of course, Sasank will give the final call on this. It has been a great meeting. Thank you, Priya, for the great answer. Girish, I have a very important question for you, which is a little tricky. I just want to ask you that, of course, we are presented here by Arpan and others. You know, I would like to discuss about Pioneer 6. Do you think Pioneer 6 is a successful trial or not so successful trial? Then I'll come to the second question.
Thank you, sir. Thank you, sir.
And all Arpan and Sunil, all of them, you focused the Pioneer 6 trial and said about it, yes.
So, thank you, sir, for that question. I think, yeah, it is tricky, but depending upon how you're looking at it.
Yeah.
So, if you ask me honestly, Pioneer 6 was a phase 3A cardiovascular outcome trial. And its primary objective was to prove non-inferiority as far as cardiovascular risk is concerned. So the aim of this study was to show that this is a cardio-safe molecule. So as far as the endpoint, which is documenting safety based on the US FDA recommendation, this study was planned. So as far as the primary objective of documenting safety was concerned, well, if you look at the 3-point MACE reduction, the hazard ratio was 0.74. 0.71 to be precise. Yeah. So almost about good amount of relative risk reduction as far as documenting safety is concerned.
Yeah. So yeah, I think it is good.
As far as 3-point MACE.
Yeah, yeah.
But then you can look at subsequent.
Yeah, you know, Girish, why this question is raised? Question is raised that they said this did not reach statistical significance. But you are absolutely correct. It was an event-driven trial. I'll just explain to you. You know, Shriram beautifully spoke about that 1.3, 1.8. You mark that, no? For the inferiority trial, 80% excess study. so that the 90% confidence interval is 1.8, 1.3, 1.3 and 1.2 keywords. To achieve that, there are a number of events. The number of events that was targeted in the Pioneer 6 was 122. So they did 122. Until the last patient, last dose, it was 15 extra, 137. In contradistinction, the second part question to Professor Girish is how does it compare to Sustain 6? Because Sustain 6 showed absolutely, as presented by everybody, it showed great, significant benefit, cardiovascular benefit.
So
superiority, yes.
So if I look at both Sustain 6 and Pioneer 6, let's understand these were again phase 3A, both cardiovascular outcome. There's some subtle differences between Pioneer 6 and Sustain 6. So as Sir pointed out, both were event driven, but Sustain 6 was not only event driven, it was duration driven also.
Absolutely, 2.1 years. Absolutely.
So duration was 104 weeks. That means it was pre-specified that you have to continue the trial for 104 weeks. Vis-a-vis, in this, it was event-driven only. That means you needed only 122 events. That means time for occurrence of MACE after randomization.
And they achieved in 16 weeks.
Yeah. So that they achieved in almost about 15.9 months precisely.
Exactly.
Whereas over here, the number of events were more because the duration was more. So that duration was 21 months. Comparatively, 21.6 months. Yeah. That's point number one. Number two, if you look over here in Pioneer 6, what they looked at is only 14 milligram dose of oral SEMA. Whereas in Sustain 6, they tested 2 doses of injectable SEMA, 0.5 and 1 milligram, both. The third difference between Sustain and Pioneer, if you were to look, in Pioneer, the hierarchical testing method that they adopted was to document non-inferiority. That means hazard ratio, to prove that 80% excess, 1.8.
Yeah.
And then they went on, which was pre-specified again in Pioneer, that then they look at superiority also subsequently. Whereas in Sustain 6, the method adopted was just to document non-inferiority.
Absolutely.
So these are the 3 basic differences that you need to look at.
Yeah.
Also, if you look at
Pioneer was not powered. It was only 122, other was 254.
So I'll just come. So
Yeah.
if the numbers were, so these are the basic differences. Apart from that, if you look at the patient profile also, in Pioneer 6, the mean age was 66. Over here, it was 64 in Sustain. Then mean HbA1c was 8.6 in Sustain, and Pioneer was 8.2 comparatively. So subtle differences between the two. So definitely, for documenting superiority, the number of events required, mandatory by US FDA, is 622. That means only if you have so many events in a time frame of 2 months, 2 years, then you can document superiority.
I think Girish has said beautifully, the Pioneer 6 was not powered to show superiority, but it did show a great deal of advancements in the cardiovascular term. It had about 122 patients and showed non-inferior. When you come to Sustain 6, which was powered, it showed head and shoulder superiority, and I think Arpan presented that. If you have a pooled analysis, Arpan, you presented pooled analysis, 26, 24. So they're almost equal. So I think Pioneer 6 is also, we can say in a way for clinical practice, show the superiority. The last panelist for today is Dr. Hemantji. Hemant, I have a very important question to ask you. The question is here. We are in India. Think India, be Indian. The question is, do we expect any change in the efficacy of oral semaglutide with ethnicity? And how it is supposed to work in the Indian subcontinent?
Thank you, Professor Dr. Das, sir. Thank you, Dr. Shashank and Nuhu, for being here. To answer your questions, so if you look at the pharmacokinetics across all race, age, sex, and even in comorbidities like renal or liver comorbidities, it behaves in the same fashion as far as the drug concentration levels. Even all ethnicity and the race, including Asians, Africans, white, black, all these are the same behavior of the pharmacokinetics is same. Once it comes to the response in terms of the either glycemia or it may be in terms of the weight loss. So if you look at the Pioneer 1, Pioneer 4 and Pioneer 8, where it is compared with placebo, with lira and even in the presence of insulin, the glycemic control is in better documented in Asians. And the reason for that is not very well explained, but I extrapolate the things, we are more carb-based diet we have it, and hence we are better responder as far as glycemia is concerned in terms of gliptins also. And in the same fashion we behaved in this group as well. And lastly, the weight response, if you look at the weight response, it performs better in lira and maybe in Pioneer 4, and even in the presence of insulin, the Pioneer 8 has documented weight loss has been shown. Otherwise, the insulin is a weight gainer, either weight neutral in sometimes. But Professor Dr. Mohan was talking about even 3 milligram has shown some kind of weight loss in some population, which we do also experience at our center also. Some patients do responded to the 3 milligram as far as glycemia control is concerned, and the weight loss is also concerned. We probably may behave differently because we have more carb-based diet. I think I
Thank you. I think brilliant answer. You know, all these oral incretin-based studies have clearly shown that we fare better than the compared to whites and the African Americans, which Professor Hemant beautifully said. And study by this gentleman sitting in front of us, Mohan, and also Singapore studies and all, showed the incretins are better effect in the Indians. So it is an incretin-based therapy. So it is a fact as clear as sunlight, as you rightly said, that this particular drug has more important effect in the Indian subcontinent race ethnicity because of multiple reasons. One may be carb-rich diet, that's from the STAR study, etc., as you rightly said, maybe many other factors. Therefore, you know, we had 4 take-home messages. You should never make it half. Number 2, it is much better than SGLT2 prototype empagliflozin. DPP4 already question was asked. Pioneer 6 did show CV advantage and CV superiority. It was not planned for that, but non-inferiority and the sustain 6 built in, they together show its superiority. And Hemantji beautifully said that it is a great, great molecule which has a greater advantage in the Indian subcontinent. Dear friends, I can see Shashank walking, and I have 27 seconds left. So any quick question? Yes, very short question, I'll give a short answer. His hand went up first, please.
Before we start the drug in our patients, I would like the panelists to tell us, in terms of retinopathy in your patients, what do you specifically ask for?
Good.
And is
I think,
retinopathy?
sir, Samasdaro Isarai Kafi, they have understood.
Yeah.
So he wants to know, Priya, in a patient retinopathy, what special care will take?
So basically, for patients who have advancing retinopathy, we need to be a little more careful, no doubt. Benign diabetic retinopathy is okay, but if they have something further than that, I think asking patients, though it has not been recommended to standardize, ask everybody for it, but screening definitely would be
So
recommended.
you mean in terms of grade 1, 2, 3, 4, and is that a complete contraindication in future, or how do you go about this?
I think if the patient has proliferative retinopathy, I think one should hold back.
Yeah.
And in terms
I
of
think-
the last thing is,
And
in
I think
terms
Dr.
of
Saab, no, before you, one more hand has gone up. Yes, last question. Shashank is on the desk, you will put me out now. Please.
Practical question. Who
Yeah.
are the ideal candidates for semaglutide to start with, oral semaglutide? What are the contraindications? Which parameters to be monitored to a patient who is on semaglutide?
Great. So we understood the question,
and,
sir.
Safety in pregnancy.
Ideal patient who will be benefiting from this patient? One line answer, it is pan-diabetic, pan-type 2 diabetic. Everybody does benefit.
Indians except
No,
who
I personally benefit.
pregnancy is not
It is to be
indicated.
given to non-diabetic, Dr. Saab, non-diabetic. What is to be monitored? Glycemic efficacy, weight, and it doesn't produce hypoglycemia, weight gain. Third thing, contraindications, everything is out. Dr. Saab asked pancreatitis, retinopathy, everything is out now. I mean, retinopathy, you know, will not be missing. And last question was?
Safety in pregnancy.
Safety in pregnancy, I
Not
don't
yet-
know.
not yet
I think,
tested.
you know,
Not yet
anything for
approved for
pregnancy, the Ministry of Health centers around mother and childhood. So anything for pregnancy, approval will come later. Thank you very much. Thank you, Shashank,
Thank
for
you,
the
sir.
wonderful.
Thank you so much. Thank you,
and-
sir. Please sit
thank you.
down.
Thank you.
Please sit down. Please sit down. I'm just going to quickly wind up. I think, we always want to finish on time because people are hungry,
Yeah.
people have flights to
Yeah.
catch. And I'm grateful that all of you all came here. We have started physical meetings. I'm grateful to Professor Mohan. That's his first physical meeting, right?
Yeah, yeah,
Please
yeah.
come up, sir.
Yeah.
Okay, put your hands together for all our faculty, all the faculty who's here. My simple take-home message
Come
is
this way.
diabetes in India is like a tsunami. It's undiagnosed, untreated, uncontrolled. Indians have complications. And timely introduction of the GLP-1 will remain sub-optimized. And we know that it's important that we are in the incretinized world. And we have now an oral incretin. And we want to, make India diabetes complications free. This is something which Dr. Mohan said 2 years ago.
Yeah.
Let's see whether this game changer can make us happen. So thank you so much. I must thank the entire Novo team and my team.
Good.
Anirudh, is Anirudh there? Anirudh and his entire team, Ivan, Anirudh, everybody, all of you all. Food is served and we can have, I'm sure a lot of people have a lot of more questions. We are all available with you all at lunchtime. We always say we should eat on time. And Vijaya and your entire team, Dr. Anil Shinde, Sri Rekha, thank you so much. Thanks for being here. Food is served. Thank you.
Thank you, Shashank, who made it happen. Big round of applause for Shashank.
They'll open the doors here so they can, everybody can have the food on this side.